Hello and welcome to our annual hearing. Welcome to the Health Policy Commission Commissioners, Chair Friedman, Chair Lawn, the honorable members of the Committee on the Annual Healthcare Financing, and members of the public, both in person and joining us via the live stream to the annual hearing. We're honored to co-host this hearing with our legislative partners from the State Legislators Joint Committee on Healthcare Financing. And our purpose today is to hear both presentations and input from those testifying that enable us to consider our thinking on the cost trend and benchmark for 2024. So as you remember, we decide that prospectively in 2023 for the next year. For those of you who have not participated in this before, let me give a little bit of background. We established a nation-leading healthcare cost growth benchmark by the legislature in 2012 and tied that to our state's long-term economic growth indicators. It's central to our efforts to contain excessive healthcare cost growth and advance affordability. Over the past 10 years, the HPC and CHIA have monitored the state's spending performance. Is that me? Or this? Against the benchmark, and have brought unprecedented transparency and accountability to our state's healthcare system. Get rid of that annoying.
I think it's because
Oh, because of the monitor? It's still there. How's that? Better? Does that sound good? Okay. Give me a thumbs down if that sound starts bothering us again. We've all been that person on Zoom who's creating that noise, so. Okay, great. And we're okay without the screen? Okay, great. So let me just review our plan for the agenda today. First, our Executive Director, David Seltz, is going to describe the process by which we consider the benchmark rate in more detail. We've been doing this for the past 7 years, partnering with the legislature to hold the annual hearing to review market data and hear feedback. And we'll talk about the process and timing for how we do that. And then we'll also look retrospectively at the data on healthcare spending and utilization with a presentation from our colleagues at CHIA on their annual report on the performance of the Massachusetts healthcare system. And we'll then hear a presentation from the HPC Senior Director of Research, Dr. David Auerbach, on the national context and affordability implications of the trends in the marketplace highlighted in CHIA's report to help us understand how Massachusetts compares to what others in the U.S. are experiencing. We want to recognize that just over 3 years to the date of the start of the COVID-19 state of emergency in Massachusetts, that the HPC board is mindful of the toll of the pandemic in the Commonwealth, and particularly in the healthcare sector. So part of what we're remaining actively engaged in is analyzing the impact of the pandemic and its effect on our spending and the follow-on effects for all of our residents in Massachusetts. As we've noted, the benchmark is set prospectively. So the question before the board and the joint committee today is whether or not to modify the benchmark for our next calendar year for 2024. And currently the benchmark is 3.6%. We will not take any votes at today's hearing. Our purpose here is to listen and absorb both the presentations and the inputs. After the presentations, we'll hear from members of the public who have signed up in advance to provide public testimony. I'm now going to turn to our co-hosts from the Joint Committee for their opening remarks. Could I ask you, Senator Friedman, and then we'll turn to you, Representative Lund.
Thank you very much. Good afternoon, everybody, and welcome to the Healthcare Cost Growth Benchmark hearing. I'm Senator Cindy Friedman, and as co-chair of the Joint Committee on Healthcare Financing, I want to extend a warm welcome and tell you how wonderful it is to see actually living, breathing human bodies in front of me. So thanks for coming. To Chair Deborah DeVoe and David Seltz and the board and staff of the Health Policy Commission, welcome. To Lauren Peters and the Center for Health Information and Analysis, which really very much looking forward to your talk, and to the House and Senate members of the Joint Committee for Healthcare Financing and other legislative colleagues in the audience, and to the patient advocates, healthcare providers, and health plans who've joined us today to participate in this very important discussion. This is an important topic that touches everyone in the Commonwealth. The Healthcare Cost Growth Benchmark is a statewide spending target established by the legislature with the 2012 Omnibus Healthcare Cost Commitment Bill, lovingly known as Chapter 224. The HPC must establish this benchmark annually, and the HPC board may modify the benchmark, as you heard, pursuant to a public hearing. I look forward to hearing from HPC, from CHIA, and from healthcare stakeholders today as we review what we knew would be another abnormal year based on the dramatic effects of COVID-19 and the effect it's had on our healthcare system over the past 3 years. I look forward to working with many of you in the weeks and months ahead on the pressing issues of healthcare cost, access, and quality, issues made all the more critical during the COVID-19 pandemic as we emerge on the other side. So again, welcome. And let me acknowledge my Senate colleagues on the Joint Committee on Healthcare Financing with us who are here today. I think we've lost quite a number of them due to the weather. I know a lot of them are stuck in their homes waiting for their heat and electricity to come back on. The members of the Joint Healthcare Committee are from the Senate, Vice Chair Senator John Cronin, Senator Julian Sear, Senator Jason Lewis, Senator John Keenan, Paul Feeney, and Senator Patrick O'Connor. Thank you.
Thank you, Senator Friedman and Chairwoman DeVoe. Welcome to everyone here today. It is good to see everybody in person. I think this is my first time in Gardner Auditorium in close to 4 years. I would like to say, I think, too, this may be the first in-person hearing that Senator Friedman and I have chaired together, having come back as our second term chairing healthcare finance. And again, my name is John Lund. I'm the House Chair of Healthcare Finance. And before I go into some remarks, I would first like to welcome Lauren Peters and Kate Walsh, the team and the new members of the board. We will very look forward to working with you both. You both bring incredible talent and dedication to healthcare here in Massachusetts. And we look forward to working with you, and thank you for your dedication to us. I'd like to acknowledge my vice chair is Kathleen Lenatra, who could not make it today, Representative Brian Murray, Representative Stephen Altrino, Representative Christine Barber, Representative Lindsay Sabadosa, Representative Patricia Duffy, Kip Diggs, representative from the Cape Cod is here, Representative Jack Lewis, Representative Chris Worrell. I know I heard from Hannah Kane this morning, who will be joining us live stream. She's out in the Worcester area buried in snow. Representative Matt Moratori and Representative Jay Barrows. So welcome, and I appreciate such a strong attendance by the committee for this very important annual meeting on the healthcare cost benchmark. It is a week, I think, of optimism. It's a week of daylight savings. We got some more daylight. We've got St. Patrick's Day. We've got March Madness kicking off tomorrow, and it is the week of our annual benchmark meeting, which really kicks off our madness that we have here in healthcare, right? And that we have to try to make sense of the very challenges we have here in Massachusetts in healthcare. But I certainly know that we have such a dedicated team, some of the smartest people I know in the country, let alone the state of Massachusetts, who are really dedicated to working on these very complicated issues to bring healthcare costs into alignment, which was on the chapter 224, trying to get to that benchmark that was set, which was not in stone, but it was what our hope was. And as was highlighted in CHIA's report that was released last week, COVID's ongoing impacts through inflation, supply chain issues, workforce pressures, and shifting patterns in patient care have brought us to bear historical pressures upon every player in the healthcare ecosystem. From where we stand today, it appears we are in the midst of a perfect storm. The COVID influence environment isn't going away, and its impacts, clinically and economically, are continuing to be felt in Massachusetts and across the United States. Yet COVID didn't cause and create all the pressures we are seeing in healthcare. It only underscores the many existing challenges already present in an increasingly complex system. So realistically, while 2020 and 2021 were challenging years, operating in a healthcare space these next few years certainly are not going to get easier. That said, here in Massachusetts, our efforts to address cost, quality, and access to healthcare must continue even as we try to figure out how to deal with the fallout of a generational health crisis. Constraining cost growth has been the driving motivation behind over 2 decades of policy reforms in Massachusetts, which is why we have convened once again to set a target, a goal, to where our collective healthcare spending should land. The annual task is setting a state healthcare cost growth benchmark is a moment of our healthcare community to reaffirm its commitment to creating a more affordable, accountable, effective, and equitable healthcare system. Looking back, while we have certainly made progress towards our long-held health reform goals, we continue to see modest results from the cost growth control policies passed over that time. But the progress made so far is just not enough. Looking forward, we must acknowledge that no one in this room has been alive at a time when we have not been confronted by the intractable problem of rising health costs of healthcare. And there is no easy solution. Continuing along this trajectory of healthcare cost growth that far outpaces the rest of the economy is not only unsustainable, but also shortchanges the rest of our priorities in education, transportation, climate action, and more. We all understand this, and we all have been working on solutions. We all know there is no silver bullet for healthcare. To achieve our goals, pursuing integrated care, innovating with value-based coverage, expanding prevention and community-based care, while also tackling costs, we should prioritize a multi-pronged agenda that addresses specific causes of the inefficiencies and market distortions in healthcare. Because people can't keep waiting for us to bend the curve to address the costs when they are standing at the edge of the cliff. There is much work to do, and deciding where to set the benchmark for the next calendar year is just one piece of the puzzle. So on behalf of my colleagues on the Joint Committee on Healthcare Financing, I want to thank you for the opportunity to address you all, and I look forward to working collaboratively with all of you, and I look forward to today's conversation. Thank you.
Thank you so much, Senator Friedman and Representative Lund. And now I'd like to turn our agenda to introduce David Seltz, who's going to introduce and discuss the benchmark modification process.
Good afternoon. Good afternoon, everyone. I am David Seltz, the Executive Director of the Health Policy Commission. A very warm welcome to all of you. Welcome Chair DeVoe and members of the Health Policy Commission Board. Welcome Chair Freeman, and through you to your Senate colleagues. Welcome Chair Long, and through you to your House colleagues joining us here today from the Healthcare Financing Committee for this really important hearing. I also want to welcome and acknowledge Secretary Kate Walsh. I think I speak for everyone in this room when I say that this was truly an inspired choice by the governor, and we are grateful that you answered the call. The challenges we face are significant, and your experience and expertise will help lead this Commonwealth in the future, and we're really looking forward to working with you. I also want to acknowledge and recognize for the first time Director Warren Peters from the Center for Health Information and Analysis, and joining us from the Administration and Finance Secretariat, Martha Kwasnick, General Counsel. Welcome. Also, welcome to members of the public who are here today and also viewing online. Thank you for your continued engagement in the work of the Health Policy Commission and this collective work to try to address healthcare and improve healthcare for the residents of the Commonwealth. We are really honored to co-host this hearing with the Joint Committee. As Chair DeVoe said, this is our 7th hearing on the modification of the benchmark, if you can believe it, and our first in person since 2020. And building on Rep. Wan's comments earlier, I do remember that we did hold the hearing in 2020 in person. It was the last in-person event that the Health Policy Commission held that year. It was the day that the NBA decided to pause its season, and Tom Hanks announced that he had COVID, and our world was never going to be the same. It is great to be back in person today with all of you. If the healthcare cost trends hearing that we hold in the fall is the Super Bowl of healthcare, then this is the March Madness of healthcare. Like that one, we can workshop that a little bit. That's fine. And finally, an additional thank you to the committee staff of the Joint Healthcare Financing Committee who really work hand in hand with our team to put on this great event. We have a really rich agenda for you today, a lot of incredible research, both from CHIA and HPC. And I really just want to emphasize that we do encourage questions, comments, clarifications throughout the entire presentations from all members here. The full presentations and a video of today's hearing, of course, will be posted online after the event. Before I begin my presentation, I also want to acknowledge the context in which we are holding this hearing. There are incredible, ongoing, complex challenges facing our healthcare system. And I could not even put an exhaustive list of all of those challenges together, but I did want to note a few. The COVID-19 pandemic has exacerbated pre-existing healthcare workforce pressures, leading to years of disruption and staffing challenges across healthcare roles and healthcare settings. It has also exposed and deepened long-standing health disparities and inequalities in access to care and good health outcomes, especially for our Commonwealth's low-income populations and communities of color. The pandemic has accelerated the adoption of new technologies and approaches that can expand access to care, such as telebehavioral health. But these gains are balanced against the sobering reality that the need for behavioral health services is at an all-time high. A recent, and in my mind, quite devastating report from the CDC on the state of mental health for teenagers in the United States found that 60% of teen girls reported persistent sadness and hopelessness, and very high rates of suicidal thought across all demographic categories, but particularly for teen girls and LGBTQ teens. At the same time of all of these trends, the cost of healthcare has only increased, leading to greater affordability challenges for Massachusetts residents and businesses. This has subsequently resulted in an increasing rate of Massachusetts residents reporting having foregone necessary health care due to the cost of care, such as skipping needed doctor's appointments, cutting pills, or not filling prescriptions. We cannot achieve access and equity and quality without continuing to focus on affordability. And I believe we must address all of these challenges together. And maybe due to daylight savings, I remain optimistic that Massachusetts, with the leaders, the policymakers, and the committed stakeholders gathered today, will once again blaze a path forward for the country. For my presentation, I'd like to provide just a brief overview of the healthcare cost growth benchmark, its history, its purpose, and its use, as well as the main purpose of today's hearing. So Massachusetts is rightly proud of its long history of healthcare reform. In 2006, Massachusetts was the first state to set as its goal. Okay. We'll just give this a second. Hi. Sorry. Well, I can do this part without the slides. That's fine. Just as a way of background and history, Massachusetts has really been a leader in healthcare policy for many decades, culminating in the Universal Coverage Act of 2006, which became, of course, a model for the country in the eventual passage of the Affordable Care Act. The legislature renewed that policy leadership 10.5 years ago with the passage of comprehensive healthcare legislation focused on moderating the growth of healthcare spending such that we could continue to afford, both from a government standpoint, from a family and household endpoint, and from an individual point of view, the rising and unsustainable rise in cost of healthcare. This law was a model for the country once again. It included incredibly new and innovative approaches to try to address the pressures that we're facing our healthcare system. To help lead that effort, the law reconstituted the Division of Healthcare Finance and Policy into an independent state agency called the Center for Health Information Analysis, who we'll hear from later today. It also established a brand new state agency in the Health Policy Commission, an independent agency led by thought leaders to really help guide the Commonwealth's efforts around monitoring and advancing healthcare affordability. I want to mention that inherent in this bill is, and this effort, is not just reducing costs at the expense of other important values. The vision of this law when it was passed was that we could achieve better care, better health, and at a lower cost, that we can achieve multiple things at once, and that this goal and the effort here today is not healthcare cost containment at the expense of access or quality, but are there ways that we can advance all of these three goals together? The central organizing principle of this bill is a healthcare cost growth benchmark. The healthcare cost growth benchmark is a target, it is a goal, it is a statewide measure of annual spending growth. And when first developed, it was the rate that we would measure against was tied to the long-term growth of the state's economy, cementing this idea that healthcare should grow. Healthcare should absolutely grow and be a part of our economy. But when it grows so much faster than everything else, it creates a true crowding out effect and a transfer of assets and revenue and the ability and inability to invest in other areas. How are we doing? I'll say a few more things just about the benchmark that I think are important. It, as has been mentioned multiple times, it is a prospective target. It is a goal. It is not a projection of what we think will happen. It is a goal by which we want to set a target for collective action to work towards. And by collective action, I do mean both government and the private and public sectors working together. It is not a cap. We have exceeded the healthcare cost growth benchmark in past years. It is not a cap on provider-specific pricing. And yet, we do have an ability to measure the individual performance of health plans and healthcare providers in understanding their spending growth rates as compared to the benchmark. The accountability tool that is set forth in the law is an ability for the Health Policy Commission Board to require a performance improvement plan of any healthcare provider or health plan for which we see that they have contributed to excessive spending growth and for whom a performance improvement plan is warranted and could result in long-term savings. This is really the accountability mechanism for the benchmark. Finally, on the benchmark, I would say that it includes all public and private spending. So it both includes the commercial spending as well as Medicaid and Medicare, and out-of-pocket spending in the form of copays and deductibles. If members would like to follow along, these slides are printed in the binders, and I'm currently now on slide 4. Great. All right, we're on slide 4. Sorry about that. So, having given a little bit of background about the passage of the law, the establishment of HPC and CHIA and our differing roles, and the goal of the healthcare cost growth benchmark, let's now turn to how do we set the healthcare cost growth benchmark? So, yeah, back to slide 4. Just back a few. For those who are following along on the live stream, they are also, the slides are available online. So I'm on this slide. How is the benchmark set? So initially in the law, it was set at the long-term economic growth rate, which is called potential gross state product. Every year, the administration and the legislature work together to set the PGSP numbers part of the consensus revenue process. For the first 5 years, the healthcare cost growth benchmark was equal exactly to that rate, and every year that was 3.6%. For the second 5 years, the law allowed for a limited opportunity for the Health Policy Commission Board to modify the benchmark to from a default rate of PGSP minus 0.5 percentage point, or 3.1%, up to any number up to PGSP, or 3.6%. So for the second 5 years, the board could modify to any number between 3.1 and 3.6, with 3.1 being the default as set in law. Each year, the Health Policy Commission did not elect to modify and remained at the default rate of 3.1. We are now in the second year of this final phased-in approach to the healthcare cost growth benchmark, where the default rate has now returned to equal to the economic growth rate, or 3.6%. But the Health Policy Commission Board has the ability to modify to any other number above or below that default rate. Last year, the Health Policy Commission Board did not elect to modify and set the benchmark at the default rate of 3.6%. Next slide. So importantly as well, as has been noted, we are setting this target prospectively for calendar year 2024. So this is really the growth rate between healthcare spending in this current year and what our goal will be for calendar year 2024. As you can see, though, we measure our performance retrospectively. As the data comes in, there is often a data lag for claims processing. So we are going to be living in multiple different time zones today. You're going to hear a big presentation from the Center for Health Information Analysis about the performance of our system in 2020 and 21 in particular. And you can see here a preview of some of the numbers. David Auerbach from the HPC will fill in a few numbers from calendar year 2022 in terms of some of the national data that we're seeing. And then we're going to hear, I think, from testimony from the public and from stakeholders about kind of what their current challenges are facing right now here in 2023. But ultimately, our mission here is to set the target for the future. Next slide, please. There is spelled out in the law a process for considering modification that includes the hearing that we are here today for, and inclusion of the Joint Committee on Healthcare Financing. The process is such that if the Health Policy Commission Board elects to stay at the default rate of 3.6%, the process is concluded for the year. If, however, the Health Policy Commission elects to set the target at a different rate, that triggers the potential for further legislative review and consideration of the HPC's decision as more fully summarized on this slide. Next slide. So thinking about the calendar of events here today, earlier this year, the administration and the legislature agreed on the PGSP target, keeping it at 3.6%. Today, we're holding that public hearing on the potential modification. And at the next HPC board meeting on April 12th, the board will consider whether or not to modify the benchmark. If so elected, there are additional steps of potential legislative review. Next slide. So setting the benchmark is only one part of this annual process for considering and holding accountable our healthcare system to spending growth. And so let me quickly take you on a quick journey down the benchmark road. So we begin every year with setting the benchmark. Concurrently with that, the Center for Health Information and Analysis collects information directly from our health plans on spending performance of payers and providers and statewide. CHIA then has the ability to, or the requirement, I should say, to refer confidentially to the Health Policy Commission Board providers, specifically primary care providers and managing care physicians and health plans to the Health Policy Commission if their spending has exceeded the benchmark. The HPC then in step 4 conducts a comprehensive review of the facts of each of the referred confidential entities alongside a number of important factors. Having done this comprehensive multifactorial review, the board then decides whether a performance improvement plan is warranted for any of the health plans and providers so referred, and finally can require a performance improvement plan, followed by implementation of that performance improvement plan. On the next slide, I want to stress that while the CHIA's referral into the HPC process is based on a bright line test of whether a specific provider or health plan spending exceeded the benchmark, the Health Policy Commission's role is really to dive deeper and to understand the context in which that spending performance happened. Was that spending performance in the control of the provider and health plan? And so you can see on this slide a number of those regulatory factors that we take into account during this confidential part of the process that will weigh in favor or against whether a performance improvement plan is warranted. So for a few examples here, we look at pricing patterns and trends over time. If we were to see a provider who has lower price levels, is providing great value in a market, but in one particular year had higher spending growth, that spending growth may be balanced against the fact that we know that they are lower priced. And so that may weigh against a need to impose a performance improvement plan. Similarly, we look at providers and try to understand their patient population mix, their payer mix. For providers that are serving a greater proportion of public patients, that again may weigh in our decision and the board's decision about whether or not to actually require a performance improvement plan. And I want to, again, just highlight H here because I do think it is very relevant for these time periods in which we'll be examining performance. Were there factors outside of the entity's control that led to the spending growth? And I think when we look at some of these CHIA numbers in particular for calendar year 2021, we know that a lot of that spending growth was due to a return in utilization compared to a pandemic year. And so that these factors will weigh heavily in the HPC's consideration in these years of whether or not a performance improvement plan is warranted. The HPC board, on the next slide, has required one performance improvement plan. So last January, having gone through that entire roadmap that I just laid out, the HPC board did, upon examination of spending trends over time and pricing trends, did require Mass General Brigham, or MGB, to file a performance improvement plan with the HPC. In the subsequent months after we gave them that requirement, they did file an initial plan. The HPC worked constructively with MGB over a number of months to refine that plan, and ultimately that plan was approved unanimously by the HPC board last fall. The plan includes up to close to $200 million in savings over an 18-month period. And importantly, includes a range of interventions and activities that will be undertaken by MGB to achieve those savings. The Health Policy Commission will be monitoring and working closely with MGB during this implementation period process. So we are in the process of evaluating this one performance improvement plan, but I would also just note that we earlier this year did complete the same cycle for the next year of data, which included the 2020 data, the first year of the pandemic. And the board, having looked at all of that data, elected not to require any provider or health plan to file a performance improvement plan, reflecting the incredible disruption that all providers and health plans faced in that particular year. This model on the next slide has become adopted by more and more states across the country. There are now 8 states with healthcare cost growth targets or goals, and each of these states has adapted this model for their own markets and environments. Collectively, these states represent 1 in 5 U.S. residents, or 20% of the U.S. population is currently living in a state that is trying to understand and bend the healthcare cost curve. We have a great opportunity to continue to learn from these other states, some of whom have gone even beyond the Massachusetts state and model. So with that as a background to the HPC, the benchmark, and the process for which we are here today, I am happy to take any questions you have about that process or the background before we turn to the Center for Health Information Analysis. And apologies again for the technical difficulties. I hope you're able to follow along.
Any questions or comments? Please.
This is you. Thanks, David. That was really great. It's always good to be refreshed. So I have to start by saying that I think HPC and CHIA are like among the best things since sliced bread, okay? So I have enormous respect. Sometimes you even spark joy when I read things that you guys put out. So please take this question with that in mind. I guess the overall question I have is, we have this goal, and the goal is to keep costs, is to look at the cost of healthcare. do we need a new goal, and are we counting the right things? Because if our goal is to actually keep costs and keep it accessible to people, if you look at the cost of healthcare and you talk to the people out there who are buying and using healthcare and health insurance, there is such a discrepancy. They just can't do it anymore. They can't pay for it. People will say, and I completely appreciate the incredible complexity of this, but they'll look at something and say, the cost has gone up 3.6%, but my premium has gone up 11.5%, and my copays are out of sight. So are we measuring the right thing? Are we, as we go into this next 10 years, are there things that certainly we in the legislature should be looking at to give us either more confidence that really is the cost, or what do we need to look at that we're not looking at?
Thank you for that question and comment, and I agree. And the Health Policy Commission has set forth a number of recommendations to evolve our approach. We have been at this for 10 years. We have made important progress, but there are real affordability challenges that remain. So for me, and I think our recommendations align with this, it's not so much about replacing the healthcare cost growth benchmark with some other target. I think it's really about supplementing our understanding, because as you said, how do people feel healthcare costs? It's premiums, copays, and deductibles. And all of those have continued to go up and up. They don't feel it in the way that we measure total healthcare expenditure growth. And they're not always one for one. They're not always apples to apples. In some cases, we're looking retrospectively to understand where spending growth happened, and that's part of CHIA's report. And then premiums are being set proactively about what we think healthcare costs could be. And so it creates a disconnect, I think, for the public to try to understand, are we being successful or not in this effort? And so the Health Policy Commission has recommended that we add to this effort by including an affordability benchmark, by including affordability standards that would be set into law to more closely be able to measure and understand the impact of healthcare spending on residents and families and individuals. This can be done. Other states are pursuing this. So I just mentioned California. California has as part of their law an idea of an affordability target, an affordability benchmark. Rhode Island, as part of their model, has, as part of the insurance review process, affordability standards. So that when health insurance plans are being reviewed on their potential premium increases, it's not just about whether they are actuarially sound. It matters to that insurance review agency whether people are actually going to be able to afford the copays, deductibles, and benefits included. There are models to draw from, and I think we in Massachusetts can learn from them and adapt and evolve our model. One last additional piece I would just add in terms of setting targets and goals. Another important goal that other states have pursued that we have also recommended is around increasing spending in areas of high value, areas like primary care and behavioral health care, within the context of a greater healthcare cost growth benchmark. But over time, can we also set targets to shift where our resources are going to the most high value and the most needed services? So I do think all of these approaches can work together and can set the stage for the next 10 years.
Thank you, David. And we've heard that, I know the governor in his bill was on investment in primary care. But how do you see that playing out, in investment in primary care? I go to my primary care. One of my people in my office just called it primary care, could not get an appointment for 6 months. And how do we have a shortage of primary care doctors, right? How do we get more access to primary care when we see that it's very hard to get an appointment? I think what the stats I've seen, 40% of people in Massachusetts might have a primary care doctor. But how do we get more people into a primary care doctor? How do we invest in that specifically?
So I think there's no one single answer, but I think there are multiple things that can work together. So one, just building off of this idea of setting targets and goals over time, so that over time we're shifting some of the dollars within the healthcare dollar into primary care and making that transparent and explicit to the marketplace. So Rhode Island, for example, had as part of their model that for insurance companies coming before the insurance review commissioner, they had to demonstrate year over year that they were putting a little bit more of the healthcare dollar each year into primary care. And the result from that state has been that they've been able to really dramatically increase the proportion of the healthcare dollar that's going to primary care. They did so without negative consequences for the rest of the healthcare ecosystem because it was done gradually and over time, and did not result in any negative outcomes. And so I do think that there are ways to set targets and goals over time to kind of shift some of the healthcare dollar over. What are we shifting that healthcare dollar over into? It has to be around expanding our workforce and going beyond just primary care physicians, but thinking about nurse practitioners, physician assistants, other ways that we can maximize the primary care infrastructure, nurse midwives. There are so many different clinical professions that we could tap into to be able to really have our healthcare professionals working at the top of licensure. And then, one final thing I guess I would say on this is that we have to do something about the administrative burden that we put on our healthcare professionals. I'm sure you've seen some of the stats from the Medical Society where they survey their members on burnout, on just the amount of paperwork and clicks that go into each individual visit. We are losing providers who are fed up with it. So I think there are opportunities for us collectively in government working with the market to try to reduce some of this administrative waste and burden that just leads to unhappy professionals and a weakened workforce. So more investments, expand our workforce, and let's reduce the burden on our workforce would be my first three things. Thank you.
Any other comments, please?
It's my first time. So nationally, CMS projects Medicare spending to increase an annual average about 6.8% through 2030. This will have a big impact on our ability to meet our state benchmark, and yet we have no real control over Medicare spending at the state levels. So should we do more to adjust our benchmark calculations so that Medicare growth out of our control does not lead to overcorrect in other areas to meet our benchmark?
Thank you for that question. I absolutely agree that as we measure performance of individual providers or of our system, we have to dig deeper than the top line number. We have to understand how much of this was Medicare, how much of this was Medicaid, and how much of this was commercial spending growth. And we're going to see some research and presentations on that today. I do think that there are potential ways that even at a state level we can address Medicare spending. And we'll present a little bit more on this, but we find that when we compare ourselves to other states on Medicare spending, we spend a lot more on hospital care. We spend a lot more on hospital outpatient care. We spend more on pharmacy than our peers just in the Medicare program. So to me, that raises perhaps an opportunity to say if we were able to work with our health systems to reduce unnecessary ED visits, unnecessary hospital utilization, if we could tackle with the federal government the cost of prescription drugs, if we can tackle the issue of people moving into higher cost settings of care, even within the Medicare program, I do think that there may be some levers that we can press on. But I think the main point you made is spot on, that our levers are pretty limited. And so it is important for us to understand that context and when we're setting goals, and of course when we're holding individual payers or health plans accountable. Again, kind of going back to that point I made before, was the spending growth in your control, and it may not be in certain areas as we see an increasing aging population and greater shifts in population into Medicare Advantage. But I appreciate the comment.
Thank you, Representative Worrell. Other comments or questions from commissioners or the Joint Committee? Okay, thanks so much, Director Seltz. We'll now turn to the next item, which is presentation of CHIA, the Center for Health Information and Analysis, annual report on the performance of the Massachusetts healthcare system. And I'd like to introduce Lauren Peters, Erin Bonney, and Liz Almanzor. Welcome, and I'll turn it over to you, Lauren.
Members of the HPC Board, Chair Friedman, Chair Lon, and members of the Healthcare Financing Committee. As noted, my name is Lauren Peters, and I'm the Executive Director of the Center for Health Information and Analysis. It is a privilege to be here today in my new role and joined by my colleagues, Erin Bonney and Liz Almanzor, to present the findings from CHIA's 2023 annual report. And if you wouldn't mind advancing to the next slide, please. Thank you. Actually, one more. Thank you. This is CHIA's 10th annual report and represents the agency's most cross-cutting publication that includes the calculation of total healthcare expenditures to evaluate the system's performance against the benchmark and examines trends in cost, utilization, coverage, and quality to inform policymaking more broadly. The findings we are presenting here today cover data through 2021, during a time in which the healthcare delivery system and the policies put in place to support it were heavily impacted and evolving in response to the COVID-19 pandemic. In light of this, I want to note at the outset a couple of modifications that we made to this year's report. During this reporting period, we saw significant shifts in enrollment across the health insurance programs. Commercial payers saw declines in enrollment, while Mass Health saw significant increases in enrollment due to federal requirements for continuous coverage. In acknowledgement of these shifts and their material impact on TME, we include in this report per member per month spending, in addition to per capita and aggregate trends. More notably, given the significant impacts of the pandemic on the healthcare system, specifically depressed utilization in 2020, followed by a rebound effect in 2021, CHIA calculated total healthcare expenditures and analyzed other relevant metrics on an annualized basis over the 3-year period between 2019 and 2021 to provide a more accurate and contextualized picture of healthcare spending and utilization. So, in 2021, total healthcare expenditures totaled $67.9 billion. On a per capita basis, this represents an annualized spending increase of 3.2% from 2019 to 2021. If we had simply compared 2021 spending to the previous year, the rate of increase would have been 9%. However, evaluating the single year trend in this circumstance fails to recognize the anomalous nature of 2020, in which we saw depressed utilization and a corresponding decrease of 2.3% in per capita spending. Accordingly, this report anchors to the annualized trends with an aim to provide a more accurate and complete picture of of the healthcare landscape during this time period. So with that, I will turn it over to Erin Bonney to present on the report's key findings.
Thank you, Lauren. And we're good on this slide for now. We'll ask. Thank you. I will do my best we're all moving ahead together. I read a lot of kids' books, 2 children, so we'll do our best. So on the components of total healthcare expenditure, which we see here, and as Lauren just spoke to, THC totaled $67.9 billion in 2021. This equates to a total of $9,715 per Massachusetts resident. And as we previously mentioned, so looking at the one-year trend from 2020 to 2021 puts THC growth per capita at 9%. But looking over the 3 years and taking into account the 2020 trends, we see an annualized growth rate of 3.2% over that 3-year period, which we have in orange on the lower right-hand corner. Looking at the 3 major sectors between Mass Health, Medicare, and commercial, all saw spending increases on an annualized basis, but again, were moderated from those higher one-year trends. Additionally, when enrollment trends are taken into account, we saw trends diverge, with per member per month spending declining for Mass Health in 2021 due to enrollment increases outpacing spending increases, and conversely, we see PMPM spending increases for both the Medicare and commercial sectors. And NCPHI has reversed trends, and we'll dig into that later in this presentation. So moving to the next slide. So looking at where that $67 billion was being spent, what types of services, here we have spending by service category. And so what we saw is that all claims-based service categories experienced spending increases from 2020 to 2021 as utilization rebounded. In that one-year period, hospital outpatient and physician spending experienced the greatest reversal of trends when compared to the 2019-2020 period prior. This resulted in lower annualized trends for those 2 categories as well. Spending for other professional services, which includes spending for non-physician providers such as nurse practitioners, physical therapists, and licensed psychologists, grew 15.9% from 2020 to 2021. Notably, this category showed the highest proportion of telehealth spending, which we looked at specifically over this period. And in discussing with the payers that submit this data to us, they cited increased behavioral health visits as a primary driver of the spending increase in this other provider category. The last category we're going to touch on this slide is that pharmacy was the only spending category that did not experience fluctuations in trend over this 3-year period. Pharmacy spending increased over both years on both a gross and net of rebates basis. On the slide here, it's displayed net of prescription drug rebates, and we see an increase of 7.5% over the 3-year period. Gross of rebates, that increase was 9.6%. Over the 3-year period from 2019 to 2021, the amount of rebates also increased from $2.3 billion to $3.1 billion. So moving into the next slide, we're going to look at the 3 main sectors specifically. So we're going to look at Mass Health first. And as a little bit of level setting, we all know that COVID has been a significant impact over these years. And so during 2020 and 2021, Mass Health provided COVID-19 relief funding to providers via enhanced payment rates, as well as through one-time supplemental payments. So in terms of where that's showing up, the enhanced payment rates were distributed to hospitals, certain healthcare facilities like skilled nursing facilities, physicians, and other professionals, and those are all reflected in the claims buckets. Supplemental payments are reflected in the non-claims category. A couple things to touch on here. So the other medical spending, which includes long-term care, home health, dental, durable medical equipment, and transportation, represented the largest service category up at the top and grew 11% in 2021 with an annualized trend of 2.4. Pharmacy spending increased by 12.9% gross of rebates and 8.6% net of rebates. Of the $600 million in additional rebates that were captured system-wide that we mentioned on the previous slide, approximately 60% of those went to Mass Health. And Mass Health has been successful in maximizing rebates through direct negotiating authority recently afforded by this legislature and through its newly established unified pharmacy product list. And we can see here on the pharmacy line, which is the second from the top, that spending net of rebates is reduced by more than half of the gross. So the net is the crosshatched, and then the gross is the colored bars that match the rest of them. So moving over to Medicare and looking at that sector on the next slide. Thank you. Hospital inpatient spending. So again, these are ranked by the size. So hospital inpatient spending represented the largest service category and increased 6.6% in 2021, which really reflected a return back to 2019 pre-pandemic levels. Some other service categories to note here are that hospital outpatient, physician, and other professional spending experienced double-digit increases from 2020 to 2021 after declines or stagnant growth in 2020. And last, in terms of the three major sectors that we're going to look at on commercial. So hospital outpatient and physician were the largest drivers of overall commercial spending increases, growing 18.4% and 14.3% respectively after declines in both of them from 2019 to 2020. Pharmacy spending, gross of rebates, increased 7.9% in 2021, which was relatively consistent in the growth in the prior year, and net of rebates, pharmacy increased 5.6%. So in our report, we look at the Massachusetts market from the perspective of this bird's eye view of how much is being spent, where is that spending going, and then as well as various market participants. So pivoting to the next slide, we are looking at the market from the perspective of the consumers. And so what we have here is private commercial premiums. So these are premiums paid by fully insured commercial members, and it's displayed by market sector. And what we see is that from 2019 to 2021, premiums increased at an annualized trend of 4.4%, with a 6.6% increase in 2021, following a 2.3% increase in 2020. One thing that's important to note here is, as I believe David mentioned earlier, premiums are set prospectively based on historical data. So premiums for plans that were in effect in both 2020 and 2021 were developed using data from before the COVID-19 pandemic, and its full impact on the healthcare utilization and system was known. Additionally, premiums in 2020 reflect COVID-19 premium credits that some insurers provided back to members in 2020 due to low utilization of healthcare services that resulted from the pandemic. And so these lower premiums in 2020, in addition to projected increases in healthcare spending in 2021, were the primary drivers of that higher year-over-year increase in the 2020 to 2021 time period. Another aspect from the consumer side that we wanted to look at specifically is enrollment in high deductible health plans on the next slide. And this again is laid out by market sector and covers the 3-year period. And in terms of enrollment in high deductible health plans, which offer members lower premiums in exchange for potentially higher cost sharing, continued the upward trend during this time period, with the biggest jump being seen in unsubsidized individual market up at the top, I think. Can't see that slide from here, very sorry. And really this continues a trend. So over the last 8 years, enrollment in high deductible health plans have tripled, increasing from about 14% of the market in 2013 to 42.7% in 2021. And while payers did not report how many high deductible health plan members had access to HSA or HRA savings account, survey data suggests that employers at larger firms are more likely than those at smaller firms to be offered these accounts, which may help offset out-of-pocket costs. Continuing on the trend of out-of-pocket costs, on the next slide we look at private commercial member cost sharing, again by market sector. And so what we see here is that the level of member cost sharing, so co-pays, co-insurance, and deductibles, varied widely by market sector. So there was so member cost sharing was $105 per member per month for unsubsidized individuals, which was more than twice the overall total, which we see in orange at the bottom. Looking at total member cost sharing, so again, this orange at the bottom reflecting the aggregate, total member cost sharing was essentially flat. It was driven by fluctuations in utilization of healthcare services, with utilization declining in 2020 and then rebounding in 2021. Specifically looking at this dip and then this increase, the 2020 to 2021 increase was driven by utilization as more members went to the doctor and there were more interactions with the healthcare system. Additionally, payers reinstated previously voluntarily waived cost sharing for certain services. We will note that in 2021, cost sharing for COVID-19 services remained mandatorily waived. And so to take these aspects of affordability and really put them in a broader affordability context, on the next slide, we have put these measures in addition to some context measures to holistically assess overall affordability. And so what we can see on this slide, everything is anchored to 2019. And so from 2019, premiums increased at a faster annual rate than both wages and salaries and regional inflation. However, it's important to note that at the same time, claims covered by insurers and self-insured employers grew faster than premiums. This mirrors the trend that we saw in net cost of private health insurance, which reflects non-medical expenses and surplus for Massachusetts residents. And then finally, over the same period, member cost sharing remained below both affordability metrics presented. And despite that rebound in 2021, member cost sharing remained below pre-pandemic levels. And I will now turn it over to Liz to discuss key findings on hospitals.
Great, thank you. So shifting focus to some of our acute hospital trends, the first slide looks at acute hospital inpatient utilization. So on this chart, it displays the total inpatient discharges at acute hospitals across the top, and then the average length of stay at the bottom. This is displayed by quarter over a 4-year period, so from October 2018 to September 2022. This data comes from the hospital inpatient discharge data in the Massachusetts Hospital Case Mix database. So prior to the pandemic, you see from October 2018 to December 2019, the discharges were relatively stable. Declines were observed from April to June 2020, January to March 2021, and January to March 2022, coinciding with the peak periods of COVID cases. The timing of those trends is also consistent with the directives to providers to temporarily suspend certain non-essential elective procedures. During this time, you'll see in the orange line at the bottom that the average length of stay has also been increasing, with greater increases seen during those periods of peak COVID cases. The increasing average length of stay can be attributed to a variety of factors, such as shifts in the type and severity of conditions presenting, as well as general throughput challenges that we've heard about. These are some of the drivers of the hospital capacity strains that have been cited. And last, it is worth noting that prior to the pandemic, we were seeing a slow increase in both the average length of stay and the proportion of discharges classified as higher severity, and these trends have continued into 2022. CHIA has reported on this in greater detail in the hospital inpatient data report that came out in December. So moving to the financial performance trends, this includes both a 5-year annual performance trend from hospital fiscal year 2017 to 2021, and then in an effort to give a look at more recent data, we've also included hospital fiscal year 2022 data through June 30th. For the majority of hospitals included, this is 9 months of fiscal year 2022. So the total margin on this slide represents both operating and non-operating activities, as well as any of the COVID relief funding that the hospitals reported. In hospital fiscal year 2021, the statewide median total margin did increase to 5.2%. However, as you'll see, the statewide and all hospital cohort median margins saw a notable decrease in the June 2022 data. The hospital fiscal year 2021 margins were influenced by non-operating margins as well as investment market activity during hospital fiscal year 2021. And so on the next slide, we look into the aggregate operating revenue and expense trends further. So this displays, again, aggregate operating revenues compared to aggregate expenses for all of the acute care hospitals. And this is only for 2017 through 2021, as we don't have complete fiscal year data for 2022 yet. So of note, this data is in aggregate and the individual trends may have varied by hospital. In hospital fiscal year 2020, we saw a decrease in net patient service revenue, which is that dark blue, most significant part of the bar. And that is rebounded in hospital fiscal year 2021. So the aggregate net patient service revenue reported was $30 billion. The revenues were also impacted by those COVID relief funding, which was approximately $400 million in hospital fiscal year 2021 and $2.1 billion in hospital fiscal year 2020. And finally, when looking at the total expense bar, which again is the gray bar on the right, you'll see that that grew to $36 billion in hospital fiscal year 2021, which was an increase of 7.1% over the prior year. The increases in expenses are driven by a variety of factors, including labor costs. And while the data isn't displayed here, we did want to make note that for the data we have through June 30th of 2022, the hospitals saw an increase of 9% in their expenses during that time period compared to the same period of the prior year, indicating that expenses are growing at a faster rate in 2022. In aggregate, in 2022, the operating expenses did exceed operating revenues during that time. So,
All right, I'll close this out here. You wouldn't mind going to the next slide? So this slide previews some of the new analysis included in this year's report, including new data and a new chapter pursuant to the mental health ABC legislation that we've included to examine behavioral health metrics related to capacity, utilization, and spending for mental health and substance use services. We've also included new data on spending and utilization related to telehealth and COVID-19 related spending on things such as therapeutic treatments, testing, labs, and vaccine administration. And then finally, on the next slide, this just previews some of the recent and forthcoming CHIA publications, which include refreshed data on enrollment trends, our quarterly provider financial report, which will include data through December of 2022, and as part of our health equity series, a new issue brief that looks at disparities in health insurance coverage between citizens born in the United States, naturalized citizens, and non-citizens in Massachusetts. So with that, that wraps up our presentation, but we would be happy to take any questions.
Thank you so much. Questions or comments? Senator Friedman?
Another group that sparks joy, even though I can only understand about an eighth of what I've been reading. So, two questions, one quick. The cost, is it through 2021 or what's the cutoff of 2019? Is it 2019 full year, 2020 full year?
And the full year of 2021 as well.
Okay, the full year for
the full calendar year. Correct.
The full calendar year.
Yes.
Okay. Is there a way that you can think of or that you've thought about to reduce that data gap? Is there some other measures or something that could give you some indication of how it's moving? It gets kind of confusing when you're looking at now at this point almost a year and a half back. So I'm just wondering, is there financial statements or something that we could encourage or help or put in place that might give us a closer to today's evaluation of what's going on?
Sure. It's certainly something that we are continuing to look at and striving to capture the most recent data available. As sort of you've seen in the presentation, the annual report is sourced through from a number of data sets at CHIA. And so, for example, the hospital, the provider financial reports that Liz presented on, we do have data through 2022. However, so that's an instance where we have the data that is final and has we feel confident in its sort of reliability, integrity. we do include in the annual report. Where a lot of the THCE data and spending numbers comes from payers, and we do need to, part of the reason for the lag is to allow for a 6 to 9 month claims run out from the data. So that is something that we are continuing to work with our partners in the payer world to help think about how can we use more recent and reliable data, whether it's from the claims, or is there another avenue in which we can collect this on a sort of a more frequent basis in more real time, so that we are not having to do such a look back. But it's something that we are very much open to continuing those conversations to provide more recent, updated, and refreshed data.
Yes, Commissioner Cutler.
So thank you for this. I thought this was really fascinating. I just wanted to, try and maybe I suppose summarize in my mind whether I think I've got it right. And so maybe you can tell me whether there's something wrong. Just if I give a quick summary of parts of it. So I was struck by a couple of things. One is that even though in 2020 insurers were sort of overpriced relative to utilization because nobody had figured out that COVID was going to happen. Over the whole 2-year period, they actually did not add to reserves. That seems to be what the chart on the private commercial affordability suggests, that their premiums went up by roughly claims, or claims went up slightly faster. Mm-hmm. So it's not like there's a pile of extra reserves sitting there relative to before COVID. I guess that's sort of one fact. And if you say, well, why did claims go up so much? It seems to me the two biggest things looking at the previous pages are pharmacy costs keep growing, and much more, I think you said mental health utilization, much more behavioral health utilization. So those are what I took as the two biggest things that were driving commercial premiums there. And so that's the first part. Let me just give you the rest of my summary and then just let you react to all of it. Then on the hospital side, so having said that, the hospital side seems less important because that's not where the growth was. But the hospital side, I took from this that there was a lot of money put in, especially if you count the federal money put in, but that seems to have basically just covered the extra costs of running hospitals during COVID. So it's not like, profit margins went up a bit in 2021 and then they plummeted in 2022. So it looks like on the hospital side, basically things they were about a wash and now they're bad. And so I shouldn't probably be thinking there for where I should be thinking savings. What I was sort of taking from this is, over the past couple of years, what I ought to think about is behavioral health care, which I'm not sure I want any savings in, and pharmacy costs. So I guess, is that a correct view of what to make of this and what to think about?
Sure. I will start and then hand it to colleagues in case they have anything to add. So I think just related to affordability, where you see that chart in 2021 where claims costs exceed premiums, I think where we look at that sort of rate of growth, I think that is really a function of the fact that the claims costs and the claims amounts were depressed in 2020. And so we see that rebounding effect in 2021, which is where you see the sharp increase in claims costs covered.
I was looking over the 2-year period.
Yep.
And saying that over the 2-year period as a whole, the claims costs are slightly above the premium growth.
The premiums. Yeah. Yes. And I think another factor there is the fact that premiums for 2020 were developed prior to the COVID-19 pandemic, and premiums developed in 2021 were really developed at a time before the full impact of the pandemic was known. And so I do think that where we see premiums lower, sort of growing at a lower rate of claims costs, I think that part of that is driven by these fluctuations in utilization and some of the sort of increased spending. Plus, we see the cost sharing down below pre-pandemic levels, which really means that payers are paying more over this 2-year period than they typically have. Some of that is due to policies that were put in place that waived cost sharing for certain services. There were other instances where the state directed sort of waiver of cost sharing, specifically to COVID-19 related services. So I think that there's a multitude of factors there contributing to the sort of incongruence between costs paid out and the premium levels that were set for those 2 years. On the hospital front, I think that your observation that the COVID relief fund, that the payments did sort of adequately offset the expenses in those years. And there would have been far more challenges during that time period had those federal and state COVID-19 relief funds not been put in place. But I would defer to Erin or Liz, anything you would add?
No? That was great. Covered everything.
So I think that's our initial reaction, but I think you're looking at it the right way.
Great, thank you. Representative Warren?
Thank you all for the presentation. It was very informative and appreciate your update last week. Question I have is, the channels which do patients access care are rapidly evolving. There are disruptive entrants into this new market, like Amazon and now Best Buy. There is increased vertical integration across traditional sectors, and now we have much concern about private equity getting involved in healthcare. And we certainly know that they're not here to improve healthcare and lower costs. So my question is, are we collecting the right data to allow us to accurately analyze healthcare spending and costs in this evolving market?
So I think that there is always opportunity to sort of evaluate what are the most challenging, pressing issues of the day, and are we collecting the right data to effectively be able to measure those things? I think there's one opportunity given the workforce crisis that is unfolding. I think this is an area where CHIA is committed to collecting more granular data on provider expenses in particular, to really be able to dig into, all right, over the course of a year, how much of your expenses are paid out on wages and salaries, how much of it is contract labor or temporary staffing. So this is something that we've already engaged with MHA and other stakeholders to refine our reporting so that we can get a better, closer look at some of the cost drivers and information and factors underlying the growing expenses. Anything to add?
Thank you.
So I have a couple questions. The first is, you guys are data experts. It strikes me that these data are very noisy. It strikes me that these data are very noisy. And is noisy. Is there anything you would, and I worry that we will be faced with setting a benchmark of some data that really has a lot of disturbance in it. David spoke of some. If you think about sort of the growth in hospital outpatient, that was probably a direct function of, inpatient beds being closed for COVID surges, and people were treated everywhere in the hospital. In our gift shop at BMC as an example. I don't know whether that's inpatient or outpatient, but people were there, and so I don't know. Maybe it's a question for us as the board, but I wonder about the wisdom of setting a benchmark against data that we're trying to understand better, particularly where you just said there's much more we need to understand, particularly about costs and what people are experiencing. I think I'm reflecting my previous role more than my current one, but in some ways, in very much our current role, because the places where you're seeing expenses are the programs that Mass Health pays for, largely behavioral health. Certainly people who need medicines who can't get them. And so I think as leaders and people who are committed to affordability, which the Healy Driscoll administration really is very committed to, I think we have to make sure that we understand these data well enough before we set a benchmark that doesn't make sense or is going to be unachievable by definition. And I just throw that out, given the fact that the last 2 years, if you look at it on average over the last 2 years, it looks okay, but there are wild swings in these data. And I'd ask people like David Cutler and people who look at information for a living to think a little bit about whether this would be the year to reset a benchmark or not. And is that too provocative for my first meeting?
We like
Maybe
provocative.
I'm just trying to get kicked off the board.
Doing a bad job of that.
So a couple of thoughts. I don't disagree that this data does, and this report, given the focus is on 2020 and 2021, and given the anomalous nature of that period, I think it is challenging to sort of make forecasts or sort of project what the trends are going to do from here. I think that once we are able to incorporate 2022 data into this spending, I think that will give us a better picture of sort of where things are going. With that said, I do think that there are elements of this report and spending that do sort of hold constant over the years, that warrant further attention. One of those being pharmacy. Pharmacy spending did not fluctuate over this period. There was a steady increase over the 2019 through 2021 period. Another constant is the continuing trend of increased enrollment in high deductible plans. So at the same time, we know cost sharing continues to increase and remain a challenge. So there are elements of this report that I think do sort of shed light on things that are less noisy and warrant focused attention. With respect to sort of spending and utilization trends and where they go from here, I agree that it's hard to draw conclusions as to sort of what spending and utilization will look like next year solely based on this report.
Thank you, Madam Chair. Lauren, thank you very much for a very comprehensive report and always giving us more to think about. My question comes to the length of stay. And I think it's fair to say that the entire system is congested. That the entire system is congested. There are many factors for that. As I think about how to tease that out and figure out the targeted responses to that, I wonder if your agency has done any thinking about how we might tease out length of stay as it relates to delays in discharge to nursing homes, to behavioral care units, to addiction services, to the whole plethora of services that we might need to discharge a patient to, including access to some of the home-based care. How do we think about that? How do we think about that? How do we capture that? Can we capture that?
So I think it's an issue that we've all been sort of wrangling with for the last couple of years in terms of the throughput challenges and the overall capacity constraint that we know is not necessarily attributed to COVID anymore, but it's really the compounded effect between workforce shortages. And then I think as we report in our findings here, that some of the drivers of the increasing average length of stay are the type and severity and conditions that are presenting in acute care settings, as well as the throughput challenges. We know that the same sort of workforce challenges that hospitals are experiencing are also being felt on the post-acute side and in the home and community-based providers. So I think that taking this data, and as Liz mentioned, CHIA does have a report that sort of dives further into the type and severity and conditions of the profiles of the individuals presenting in our hospitals that I think will help us sort of be able to quantify how much of it is it that versus how much of it is attributed to the throughput challenges, and where do we need to sort of dedicate or allocate resources to help improve access and sort of free up and tingle some of those bottlenecks.
Representative Barber?
Thank you for this presentation. I appreciate the work that CHIA does generally, but especially the work you've been doing on health disparities the last few years. So you touched on the consumer experience in some of this. Do you have more data on health equity and disparities and who is most struggling to afford care in this report, or is that in other reports that you're looking at? Is there more you can share about that?
The equity series, and we've issued, I think the first brief was issued at the end of last calendar year, and as I mentioned, we have another that's set to come out later this spring, and that really does get granular by demographics. But can you speak to, are there other places in this annual report that stratifies, or is it primarily the health equity series?
So the Health Equity Series is a really good resource. We also, a lot of our data on equity and on affordability from the perspective of the consumer comes from our Massachusetts Health Insurance Survey. And so that's a really robust data set. So we do have those questions of how many residents reported that they were not able to access care they needed due to cost. And a lot of those measures are able to be broken down by race and ethnicity. So the MHAS, it's a separate report, but it is out there. And I think we published it earlier this year.
So, and yeah, I would think about it sort of as the annual report is sort of the sort of broad brush, sort of at the macro level, we talk about affordability, and then our subsequent sort of issue briefs are like the double click into a lot of those issues where we do stratify by race, ethnicity, and the like. So we'd be happy to follow up with your office to make sure. We know that we put out a lot of publications, so we're happy to follow up with you and provide you the direct links to some of those data briefs. Mm-hmm. Absolutely.
Commissioner Master Giovanni?
Thank you. Great job, as usual. The level of detail is always very impressive. What I was thinking about was, in order to come up with the benchmark for 2024, 2023, 2024, when we look at that, does it make sense to actually talk to firms like, I know the HPC had historically contracted with Milliman for projections to take what you have and then look at projections that some of the major firms in the country are coming up with that may actually help us come up with that projection, unless you folks can actually make the projections yourselves. But you can take their projections and integrate it with what you have, and they can break it down, I think, not to the level that you folks do, but they can certainly break it down to the various commercial levels as well as Medicare and exclude Medicare if that's what you would need to do in order to come up with the projections. But they would have that, and I think that may be helpful for us in terms of trying to come up with a number. I don't know, what do you think? Have you looked at that?
We have not specifically looked at sort of contracting with an outside firm to run those projections, but if that is something that others are interested in pursuing, I think CHIA, in our role as sort of the data hub, we are more than happy to think about ways that we can sort of use our data to source that type of analysis.
Any other questions or comments for CHIA? Am I missing anybody? Terrific. Thank you so much for a very clear, comprehensive presentation. Appreciate it. Our next presentation is on the National context and affordability implications for Massachusetts. And I'd like to introduce Dr. David Auerbach, who's the Senior Director for Research and Cost Trends from the Health Policy Commission. Welcome, Dr. Auerbach.
Hello again. First of all, just kudos to Director Peters and the Center for Information Analysis team for that great presentation. I wanted to follow up and provide a few thoughts on some of the questions and comments that were made as well before we dive into the next part of the presentation. I do actually want to commend the efforts of CHIA over the years to increase the speed at which we're able to get this data. Actually, in the last couple of years, we actually worked with the health plans to rejigger kind of when they submit claims data to us so that we can do this final evaluation. Under the previous system, we would not have had the final numbers for 20 to 21 until October of this year. So we've advanced it at least this 6 months into March. I think there are obviously more opportunities for improvement, but I do want to commend them for their continuous efforts on that point. And as she alluded to, there are data that we do get even faster now, and they've made a lot of improvements there. So the hospital discharge data, inpatient discharge data, so we can see how many hospital visits there are, where, how length of stay. All of that data we're now getting on a near quarterly basis. And so that has just been a tremendous asset to the Commonwealth, especially in the COVID response time. But look forward to continuing that work because, as many have mentioned, we are looking into the past and trying to reflect and understand a very disruptive time in healthcare, but also trying to set goals and targets for our future work. Representative Lawn talked about, needs to perhaps evolve our data to reflect a rapidly evolving healthcare delivery system, especially with regard to new market entrants, new expansions, new joint ventures, the entrance of private equity. I would reflect to this committee and to the board that is a research project that we have undertaken, is to try to understand the penetration of private equity into the healthcare as just a first space to start. Let's see what the baseline is, and then we can try to understand its impacts over time. But I do think that there are opportunities to enhance and evolve our approach to some of the market review work that the Health Policy Commission in particular is involved in. We have some recommendations about that, and there has been legislation proposed by the Speaker in the last session that would look at what gets noticed to us. And I do think that some of that could probably benefit from a relook as well, because a lot of and I am not a health economist, but a lot of the economic theory that many of these reviews was based on was really around kind of like horizontal consolidation, hospitals buying hospitals. And what we're, of course, increasingly seeing is that it's hospitals that are a bigger part of health systems, that are buying nursing homes, that are buying home health, that are now expanding into pharmacy. And so this has really kind of changed the market dynamics. And then, of course, the entrance of private equity. So I do think there's opportunities for us, perhaps, the board and the committee, to think about how we can involve those. I think in terms of cutting through the noise of this data, Secretary Walsh, you're absolutely right. I mean, if you look at the individual years, the large swings, and I think from firsthand experience that so much of this was being driven by policy decisions that were happening rapidly in real time that had implications not just for of course, the hospital, but across the entire continuum, where we were seeing ripple effects from the emergency department to inpatient to skilled nursing facility and into the home. And some of those are still being untangled today. So I do recognize that it's always kind of a strange moment in these hearings to look back 2 years on data and then try to think about what we want to try to set as a goal for the future. And that is kind of what we wrestle with here. To help us try to pierce through this cloud, we did have an additional presentation to try to, as Director Peters said, kind of pick out some of the signal from the noise. And to help do that, we wanted to both expand our time period, so we're not just looking at this 2 years of extreme disruption, look over multiple years to compare our performance to the nation, and then to reorient us again about why does this matter? It matters because people are struggling to afford healthcare. And so with that as kind of an agenda for this presentation, I will turn it over to David Auerbach, and please speak into the mic.
Okay, I will. All right, thank you, David. And thank you, everyone, for being here in person. I am so jazzed to be here in person. It's great. It's fantastic. Is that working now? Okay, wonderful. Okay. All right, so this talk, it'll be in 3 sections, as David mentioned. I'll just say next slide, please, because I'm not sure it is. But the first section, I'm going to talk again about some of the recent spending trends that we've seen in Massachusetts in national context, putting that over the longer trend, building on CHIA's report. The next section, I will talk about, are there opportunities for saving money in healthcare? And I think, yes, there are. And I'll just go through some examples of those where we have excessive spending with no value. And then as a final section, bringing this back to affordability, as David said, and implications for consumers and residents of the state. So to start out, I'm just repeating CHIA's graph here just so we can orient to that again. This is our long-run performance each year against the benchmark, and the pattern of the last 2 years, again, where we were negative growth in 2020 and then high growth in 2021, averaged out to 3.2% per year. And a lot of the slides I'm going to show, I'll be doing the same thing of averaging out 2020 and 2021 to give you an average annual trend because of this up-down pattern. Okay, next slide, please. Oh yeah, and the long-term, so taking over the entire 8-year period, our long-term average spending growth was 3.52%. A good number to know. Okay. There we go. All right. So now looking over the last 20 years, that same trend in our average spending growth per year, how does that compare to the US? We've shown this every year. We were tended to be higher in the 2000s, and then we were below the national trend for most of the 2010s, and we were a little bit below in 2020 and in 2021 also, a little bit below the national trend. But underneath this, there's a lot of interesting differences that I will be getting to. Okay, now important context to know that CHIA also covered. We've had a really big shift in coverage over the last 2.5 years. And here I'm comparing March 2020 to September of 2022. The percent of Massachusetts residents with commercial coverage, whether that's through their employer or on their own, it used to be 62.8%, and now it's about 58%. It dropped about 4.5 percentage points. That's 300,000 Massachusetts residents have basically shifted from commercial coverage to Mass Health. So that's an important trend for those individuals involved, and it's important for the spending trends because Mass Health tends to pay much lower than the commercial pays. So that trend has reduced our spending, and it has implications for providers as well. Providers are getting a lot less revenue for those Mass Health folks than for their commercial members. Okay, so keep that in mind. So what we're showing here is, controlling for those changes. We're showing changes in spending per enrollee, whether you have commercial coverage or whatever. And CHIA did some of this with the PMPMs as well. So there's that overall 3.2% trend, but now if you look by market, it's very different. For those with commercial coverage, the trend is about 5%. 5% growth per year for commercially covered people, okay? So that's much higher. For Mass Health is actually negative, as CHIA showed. In 2021, the average person on Mass Health had less spending than they did in 2019, which is really quite remarkable. And in Medicare, the trend was about 3%, so in the middle there. All right, so that's important to know, and I'm gonna focus a lot on that commercial trend. What's driving that commercial trend, and why is it so high? And in fact, this will also show that it is high. Comparing our commercial trend, Massachusetts, to the rest of the country, again, we were below that trend in spending growth from 2013 through the 2010s, and now we're definitely above the last couple of years, where the US trend has been about 3% and we're in the 5-6 range. Okay, so what's going on? We're gonna try to break that down as much as I can in the next few slides. I do want to thank the folks back there from my team. We have had the all-payer claims data for only 3 weeks, and they've done an incredible deep dive into the millions of lines of claims. And so we will have more with our cost trends report, but I'll show you what we have. Thank you. It's true. So we'll try to break down that commercial trend in a number of ways. One of the ways that's very important is it prices rising, or is it people using more care? And we've shown this before. From one large payer, they break that down in their own data. And the orange is the price growth, the blue is the utilization. And in their data, the price growth has been more and more and more each year. So in 2021, it was about 2.8%, and that's their perspective on prices, which they call unit cost. This is dividing that commercial growth by category, as CHIA did some of as well. But here it's per member. And I've ranked the categories by what grew the fastest to what grew the least fast. And as we saw in the CHIA data, number one is prescription drugs. That you get at the pharmacy, 7.7% growth per year. That's including rebates. That's very high. But next is actually hospital outpatient spending. So Dr. Cutler, that actually was pretty high, is the hospital outpatient. That grew 5.4% per year per member. And what are we talking about? This is about a third of commercial spending. This is your minor surgeries, colonoscopies, labs, tests, even simple office visits, but they happen to be in a place that's part of a hospital and bills as a hospital department. Okay, I'll talk more about that. Third fastest growing is your hospital inpatient, which we all know about. And then the regular office visits, the retail clinics, the urgent care, that grew the least fast, just 1.2%. So to kind of think about drug spending, there's the retail spending you get at the pharmacy, and there's also, very important, drugs you get in a physician's office, often in a hospital outpatient. This is your chemotherapy, this is drug infusions. They make up about 8% of commercial spending. So if you add your retail drugs and your physician-administered drugs, that's now 25.5% of commercial spending. It's a big chunk, and that's growing. It's more than it used to be. Okay, so some deeper dives into the things that I've just said. This is a comparison to the rest of the country from our Medicare folks. It's a good way to compare apples to apples because it's the same program, it's the same sort of beneficiaries. Our growth was faster, again, in hospital outpatient. It was faster in pharmacy than the rest of the country over the last 2 years. Okay, now back to prescription drugs to focus on that. What is driving that big pharmacy growth that we saw? It's mostly the prices. We're showing the average price of a branded prescription for the last 5 years, and that price has gone up each year. It went up 15% in 2021 to over $1,000 on average per branded prescription, where 6% of those prescriptions were over $5,000. Now that's not accounting for rebates in this graph, but that trend is still an increasing trend. This is out-of-pocket spending for prescription drugs. That has also been growing, and we're highlighting a few categories of drugs: MS, arthritis, diabetes. More than 60% growth in your out-of-pocket spending for a 1-month supply for folks that are buying drugs in these categories. That's a lot of growth. Here, to dive a little deeper in the hospital outpatient category, there are a lot of subcategories here that we're showing. Where is the growth highest? It's a lot of your routine procedures, minor surgeries, biopsies in that first category, 7% per year. Drug infusions, chemo, we've talked about those before. It's the drug prices going up. If we look at prices versus utilization in this hospital outpatient, it's all price. It's all price, and it's all the prices that goes to the hospital. Note that for stuff that happens in a hospital outpatient, there's a hospital payment usually, and then there's a physician payment to the clinician who's doing the procedure. So it's the hospital piece that's growing, and it's the prices of the hospital piece that are growing. And there's a little bit of COVID test and vaccination that also grew here, of course. Okay, so that's what we know about some of the trends in spending drivers. Now I'm going to highlight just some of the maybe low-hanging fruit of where we see a lot of spending without value and that we might think about. We'll talk more about this in the cost trends report this year, but here are some examples to highlight. Okay. Ooh. There we go. Okay. Number one, excessive utilization of care. This we showed earlier, but it's worth mentioning again. We have the 6th highest rate of avoidable hospitalization in the country. And that's after West Virginia, Kentucky, Mississippi, Louisiana, and Alabama. We're number 6. And I'm not sure anybody had really figured out why we have the 2nd highest Medicare readmission rate. And this is despite being one of the healthiest populations in the nation. So it's worth exploring more to figure out why this is. But we know that our hospitals are at high capacity right now, and some of the folks really don't need to be there. It's important to know. In picking on certain categories of spending, the same ones again, this is our Medicare spending per person, us versus the US again. Where are we higher? Again, we're higher in the hospital outpatient, we're higher in the pharmacy. And that hospital outpatient, you see we're lower in the physician category. Again, a lot of our office infrastructure is owned by hospitals more than in other states. And so they're often billing at a higher hospital rate than an office rate. That's a substitution, and that's why we're higher there. It's a lot of the reason. Showing some variation in prices for services that have very little variation in quality. This is a market basket we created of 50 common hospital outpatient procedures. This is again your colonoscopies, physical therapy visits, lab tests, images. And depending on what hospital you go to for the same exact services, you could be paying anywhere from $20,000 to $50,000. Same stuff. If we look at lab tests, even more of a commodity, we see variation that's almost 5 times just based on where those lab tests are performed. We have on the right is about what Medicare would pay, $3,600 for the same panel of 50 lab tests, whereas some hospitals you would pay $15,000, $20,000 for the same ones. We looked at variation in the price of those physician-administered drugs. All hospitals pretty much are buying these for the same rate, but then how much, when they use them in patient care, how much did they get reimbursed by the payer for those drugs? For some hospitals, it's about 6% over what they paid, a 6% markup. For some hospitals, it's 100% markup, even more than that. Same drugs. It's just how much they're being paid when they use them. Okay, and finally, some trends in inpatient spending. Commercial spending per inpatient discharge, I've shown this before, it's gone up from about $14,000 in 2013 to almost $21,000 per discharge. That's a 50% growth. And over that time period, total assets on net held by Massachusetts hospitals almost doubled from $22 billion to $41 billion. It's related to these increases in revenue per patient. And as David highlighted, I would have one thing to say about 2022, but it's national, it's not within our own data. But again, this is tracking national hospital prices. What's the annual growth in hospital prices? In 2022, it really spiked. So we're not sure yet if we're seeing that in Massachusetts. It'll take a little while, but if that is what we see here, that's not boding well for our cost trends in 2022. And finally, I talked about a lot of prices. There is, again, more types of care being delivered where there's opportunities for savings. We track low-value care every year. Care that's not evidence-based, that does nothing for the patients. For example, people getting pre-op tests that aren't needed. We all know they're not needed, but often it just keeps happening because it's the routine. 20 to 33% of patients are getting unnecessary pre-op tests. And it varies by provider group, but it's high, and we're trying to work on that. It's difficult. This is showing differences in prices paid for drugs, and we're going to talk more about this too. And we know that in this country we pay a lot more for drugs than in other countries. This is an example of Jakafi, a common drug for oncology, 5 times the price that we pay than other countries pay for the same drug. Okay. So that was a whirlwind of some examples. I hope you're not overwhelmed. But let's try to bring this back to, again, what does this all mean for patients living in this healthcare system that we have? This is showing the trend that CHIA showed of high deductible plans, but I'm just extending it back to 2013. It's remarkable growth from about 15% of plans were high deductibles, and now it's 43%. And what that means in 2021, that's a $2,800 deductible for a family or more to be in that category. So it's almost half. And why is that happening? Here's part of the answer. I mean, this gets a little bit at Senator Friedman's question. We do often hear people saying, I'm facing a premium increase of 10, 11%. That's what they're telling me. How come these commercial trends are 5%? It's partly this. This is the rate increases for the same plans that are announced and averaged by the DOI, and these are 6, 7, 8%. So then what happens is the company says, I can't afford an 8% premium increase. Well, I'll just have to increase my deductible to try to bring that down to 5%. And so we tell you that the premiums went up 5%, but it kind of went up 8%. You just bought down your benefit a little bit, and then the high deductible plans go up. So that's kind of what happens, and this is an important part of the story. This is what people feel and face. If they were to keep their same plan, it's more like 6 to 8%. And as a result of that, here's the trend in people avoiding care because they can't afford it. And it's at all-time high. This is national data, but we see numbers like this in Massachusetts. 38% of people said, I have put off care in the last 12 months because I couldn't afford it. And most of those, it was for a serious illness. It wasn't something minor. And you can see, that tracks, that's double what it was in 2001. Well, healthcare premiums tripled over this 20-year period, and care avoidance doubled. And those are surely related. Let's look at the Massachusetts small group market. The blue bars are showing the number of people covered through employers from size 2 to 50. And it has really shrunk. It's almost half of what it was 10 years ago. And at the same time, the percent of those in high deductible plans went from 35 to 72%. Most are in a high deductible plan. Their cost sharing has doubled over this time from $1,500 to $3,000, and those premiums have gone up. And the increase in those premiums is faster than wages for people employed in small firms. They tend to have lower wages than people in larger firms. And if you want to look for an affordability canary in the coal mine, it's probably here. This market is not doing well. And finally, just to have one number to maybe stick with you, $25,000 is the average cost for a family's health insurance plus their cost sharing in 2021. $25,000 a year. And it's more than the cost of a new compact car. It's half of the wage of an LPN for a full year. And, it grew 31% since 2011. The growth from 2001 to 2011 was higher. It was a doubling, and it's grown 31% since then. So we're doing better than for the first decade of the 2000s, but that's still faster than the wage of that LPN. It's faster than the wages of a lot of middle-class residents. And that's really, I think, the goal here is to try to keep those numbers in line. Okay. Are there any questions? From that. It was a lot of numbers.
Senator Friedman?
I'm not responsible for the level of questions I'm about to ask because that was so overwhelming.
Sorry.
But here's what I keep coming back to. I'm really concerned about what and how we're measuring things. So as just a person who is not steeped in this, right? You look at something like, I think it was on 13, where the procedures and surgeries have gone up, right? Well, don't we expect them to go up? Don't we do more things in outpatient, and shouldn't those numbers go up? Is that telling us something good, or is it telling us something bad? We see that the hospital numbers are increasing, but we just got told that there's a whole bunch of people in the hospital that don't have anywhere to go. So you would expect the numbers to go up, right? You see what I'm saying? Like, what are we are not getting to the core of this. And so how should we change the way we measure? Do we have to get more granular, and an overall cost benchmark doesn't really tell us what we need to know? I see all these numbers. Where's the low pay, the people with no money, where are they going? And where are those, you know what I mean? Are those numbers going up? Well, we know there's a lot of stuff going on there, but we don't, you see what I'm kind of struggling with here? And where are the insurers in all this? Like, there's nothing about insurance here. And we know they're not just sitting there going, oh, yeah, well, we can't do anything, right? So you see what I'm struggling with here?
Yes, that's a lot of, I will do my best. That's a lot of questions. I'll see what David says too. I think the price versus utilization distinction is really important. And when you're saying, yes, there has been some shifting of stuff from the inpatient to the outpatient. There's always some, but it doesn't dominate all the trends that we see. There is some. We've noticed that, for example, we all saw the hospital admissions going down. They're still down 8%. And we were looking at hip and knee surgeries, a common inpatient admission. And they had dropped like 40%. And we were asking ourselves, what's going on? How can 40% of people that would have gotten a hip or a knee replacement not be getting it? And we were able to look a little bit in the data, and some of them have shifted to an outpatient setting for that. Some have. But not that explains all of that drop. It doesn't explain all of that drop. And I can't say we really know how to explain all of that drop. I've talked to a physician friend of ours. He said some people are just living with whatever they have and they're making do. Some people are using other methods to deal with it, and some people probably are getting better. Some of those might have not been necessary in the first place, and when people can't get in to schedule an appointment, I'm sorry, can you say it?
They were the cases that were canceled every surge that we had over the last
there's all sorts
2
of things.
years.
Exactly.
Yeah.
There's all sorts of things going on. And so so that was kind of somewhat of an aside of utilization. But when we see that surgery and procedure spending going up 7% per year, yeah, we need to parse that more. Part of it is people getting stuff they need that they couldn't get over there. But most of it is just higher prices for the same stuff. And that has a very different implication. And I think that's really important for the tools that we have and for us to think about. Because how much more should we be paying for the same stuff? What is reasonable? What is fair? And that's going into our premiums. And so in that whole hospital outpatient bin, we showed that it is mostly about prices going up for the same stuff, not for more stuff. So that's what I can say about that. Where the insurers, I mean, there's a lot to that. I mean, insurers have a set of tools that they use to try to control costs. And then there are some cases where there really isn't that much they can do. And we talk to insurers all the time. And you know, when it comes to a hospital that they must have in their network and the hospital is saying, I need this price increase, the insurers often have not a lot of power to control that. And we hear that. Is that controversial to say? I mean, what do you want to add to that? I mean, there's not a simple answer. I mean, most of the variation we see in spending is not based on what insurer you have. It's mostly based on what providers you are using. Okay, and we see that every year. It's just true.
Yeah, I just guess I would respond and not to pick on the insurers, but I think we have to pick on everybody here because It's a total package. I am kind of interested and a little bit awed at the reserves that we are seeing in some of these insurance companies. And we now have more and more companies getting into the business of insurance that are for profit. And so I think that is just not a comment to you, but it's a comment to all of us that we can't wait anymore to sort of do something about for-profit and private equity. Because I think it's eating us up and it's going to get worse. And I completely understand what you're saying. I just think it's more incumbent on us then to figure out how to measure and what you do when you see these kinds of increases, right? And it can't be just an overall, we're going to bring the cost down, or we're going to keep the goal at this. We really have to, unfortunately, start, I think, looking at some fundamental categories, as you're saying, and saying, okay, what's going on here, what's going on here, and what's going on here, and how do we independently or individually manage that? Because we're not getting there, and you have shown how we're not getting there. So no picking on you guys or anything. I'm just sort of overwhelmed by what we're seeing, which is really alarming.
Yeah. Okay. And I should give you at least one more statistic on the insurers that we have that I didn't put on the slide, but where I showed the hospital assets increasing from 22 to 41 billion over that slide, we were able to find that a comparable figure of insurer assets for the top 3 insurers grew from about 2 billion to 3 billion over part of that time period. So, we should have all the numbers, but it's a smaller growth.
But that's net of risk-based capital. I frankly don't believe that number.
That's capital plus surplus.
But it's going to be net of risk-based capital. I mean, it can't. Okay, well, we can argue.
We can talk about that.
Right. And we will hear public testimony from the Mass Association of Health Plans later, so we can talk a bit more about insurers. Commissioner Cutler?
So I was doing sort of the same thing that Senator Friedman was, which is trying to, in my mind, put together a strategy or a set of priorities. And so based on your presentation and the earlier ones, I sort of wanted to give my list of 3 things and then have you react to it. So the first one, which both you and CHIA mentioned and jumps out in the data, is pharma prices, where Mass Health has done a very good job, but private insurers have been much less successful, and Medicare Advantage plans have been much less successful, and Part D plans have been much less successful. So that's the first big item. The second big item on my list is the unit costs. And to me, the biggest thing there is the administrative costs that drive up the unit costs. So if you could lower the administrative costs, you could then lower the unit costs without reducing anyone's margins. So you take out some of the people who don't need to be there, and you lower those costs, and then you don't have to pay as much. And so we've spoken about that, but this sort of, your presentation kept reinforcing that in my mind. And then the third one, which I think you also spoke about quite well, is we still haven't brought enough rationality to what care people get, what services people get, and what they don't get. And there's sort of 10,000 different examples of that, from excessive testing here to excessive rehospitalization here to excessive use of institutions instead of home and things like that. And that whole rationalization business has not gone as rapidly as we would like. Of those 3, I mean, those are all 3 difficult problems. Of the 3, I wonder if the third of them is maybe even the hardest, even though we've probably spent the most time on it, just because it's got so many independent parts and so many different things that have to coordinate. But I guess sort of my way of rationalizing things is that those are probably the 3 biggest areas that we kind of need to keep in our brain. But I don't know, do you want to add or subtract to that list at all?
I think it's a good list. I think the last part of this presentation was to lay out some of our policy recommendations from the report that align with that. I would just add, and I think this difference between price growth and utilization growth, and where there is variation in price growth, where certain providers are able to negotiate higher unit prices for the exact same services, is also a dynamic that impacts unit prices. It's not just administrative costs, and so market functioning, negotiation, leverage, those I think need to be a part of the mix.
I'm happy to add that to the list too.
Thank you, Madam Chair. Thank you very much for your presentations, and they've all been terrific. I want to touch upon mental health and behavioral health in hospitals. As we know, they're overwhelmed. And is there any sort of analysis, or are you breaking some of this down to see, is this increasing the cost because we don't have enough providers to provide mental health services? So where are they going first? They're going to the hospitals, the emergency rooms. and then they're doing all these tests and all this other stuff. Is there any way to look at that, or do you think that down the road, as we do get more providers and we change how we're dealing with mental health, that may have an effect on costs? Does that make sense?
Absolutely. Great point, Representative. And I'll let maybe David speak to the economic literature on this, but we have absolutely seen an increasing rate of, ED boarding is one of the indicators that we look at this. How long are people staying in the emergency department before they're moved to a more appropriate setting? And that has increased. I think the rates that we saw now were close to 50% of Massachusetts residents who present in an emergency department with a mental health condition are there for more than 12 hours. And that is like an increase, I think, from the high 30% to almost 50% just in the pandemic period. It's to me almost a humanitarian crisis in some respects. And so the theory and the goal, and I think a lot of organizations are really working hard to say, how do we intervene with patients and provide them supports in the community so they're not presenting in the emergency department, which is often cases not the most appropriate setting of care for these patients. And Secretary Walsh, you should speak on this more eloquently than I can. So are there ways to do crisis intervention in the community? Are there ways to expand access? And I think the roadmap to behavioral health is I think, absolutely worth pursuing in terms of thinking about guiding our investments. We have a lot of psychiatric inpatient beds that we've actually grown in the last couple of years, but many of them aren't accepting patients because they don't have the staff. And so, again, there's a misalignment of capacity and workforce, which is going to be, now wait for the pitch, this is going to be a big topic of conversation at an upcoming workforce event that the Health Policy Commission is pursuing, where we looked at behavioral health workers in particular, and thinking about these changes in these different settings. But I think it is absolutely worth tracking. I'm going to commend, again, CHIA. They have expanded their behavioral health reporting. And one key area that we haven't always had a lot of insight in is utilization at freestanding independent psychiatric hospitals. We know a lot about what happens in the acute care hospitals. We haven't known a lot. CHIA is now getting more information about, kind of where are those patients going when they leave an emergency department. And again, are those settings matching the the clinical needs of patients that, again, pediatric patients, specific patient needs that sometimes prevent patients from being able to be placed. So I think there's just, a tremendous amount of energy on this topic, and I think worthwhile. We need to continue to push forward and push forward even faster. We will continue to try to bring data to bear on that.
Yeah, I'll just add one more thing. That in terms of, in the big picture, there are very few things where if you just did nothing but invest more money in one aspect of the healthcare system, that you would save so much more from preventing bad things that happen that it would be on net saving. And I don't think there really are anything that fits that category. Very few. In primary care and behavioral health, probably you wouldn't save money by just investing more and doing nothing else. But if you invested more in those areas and kept the total pie the same, so the proportion was higher, you would definitely have a more efficient healthcare system. You would. Yeah. And I think that's the idea behind, we make this recommendation in our system as well.
Thank you. 1 second. Representative Diggs?
Thank you for all this. So I live on the Cape, and our population is elderly. So our hospitals deal with Medicaid, Medicare, for the most part. So even when you said, to get a hip replacement, well, Cape Cod Healthcare, next, they stopped doing that because the last 2 years has been crazy. They kind of just opened back up again. So, of course, the prices are astronomical.
Yeah.
You know what I mean? So, what am I saying? I'm saying. So we're dealing with Medicare so much that, they're only getting that 80, they're only getting 75 or 80% of the money instead of getting that dollar. When if you're going to get a hip operation, you're going to get that, whatever it is. You know, so I guess that's the problem that I'm seeing, at least on the Cape, that we're having.
Yeah, absolutely. And I think when we look at price variation, it's important to try to understand what may be the drivers of that. And you know, for a hospital like Cape Cod, a hospital like the Island hospitals, even Berkshire, these are geographically isolated hospitals, and that, you know, need to be there to serve those communities.
Yes.
There are other providers where we see very high price increases for, who do not have predominantly Medicare and Medicaid patient populations. They have predominantly commercial patient populations. So you might think about those providers differently than providers that are treating a high proportion of high public payers. And that's when we ever think about accountability to the benchmark or through the performance improvement plan process. That's why we have to understand the very specific context of the organization that we're looking at, because all of those things you may say, okay, they charge higher commercial pricing, or their commercial pricing went up, but 90% of their patients are Medicaid and Medicare. Is that concerning? You know, so the context matters. Payer mix matters when we think about commercial price variation. It's a very important point. I'm glad you raised it.
Thank you. Representative Keenan? Did you have a question? Yes. Sure.
A couple observations and then I guess related questions. And I think Chair Friedman touched on some of these kind of the contradictions that we seem to have and trying to figure this information out and where does it really lead us. So I looked at a couple things. The commercial spending growth is up 5% compared to 3% in commercial as compared to Medicare and 1% for Mass Health. And then we have hospital outpatient spending for Mass Medicare beneficiaries, which is 31% above the national average. And then we have total margin trends that show most recently teaching hospitals are down about 7%, down to a negative 7%. And that fluctuates in comparison to other types of hospitals and facilities, but it recently seems to be tighter margins in some cases for some of the teaching hospitals and academic hospitals. And then when we look at prices for the services provided, which is, you know, one of the responses was that there are higher prices for the same stuff. And so as I look at that, when I see some hospitals struggling with margins, when you see that they are charging more for basic services, for that kind of that market basket of 50 different services, including lab services where they're charging more, if there is success in addressing those higher costs for those type of facilities, can the savings be realized to some degree as it was with Mass General Brigham in their performance plan, performance improvement plan? Is there enough to be saved there to prevent savings in how we provide lab services and 50 other services, so that there is still a margin for these hospitals? In other words, we're going to cut costs on all of these. We know we can do some savings through a performance improvement plan. Is the net something that will allow these hospitals to still survive and provide quality service?
It's a great question. I will answer in two parts. One is to say we are actually preparing a white paper on this very topic of actually kind of modeling what would happen if we say capped the prices of just say labs at 200% of the median. You know, so it maybe cuts off some revenue for the top end providers that charge the most. Well, how much money does that save? What would that mean for the financial or revenue position for those hospitals? So that's the type of kind of granular modeling that we're working on right now to help inform these discussions, because you're absolutely right to ask, well, if we did something about pricing, what are the implications going to be? Where do we even think about what is the right place to set that? And I would also add, I think there's distinctions between, perhaps, cutting the top off at a certain point or capping the top versus growth. And so is another approach to say, we're going to moderate or restrain the growth year over year so that the lab tests, instead of growing 5% every year, maybe it grows 2% every year. So you're not, it's not taking money necessarily out of that provider's budget today, but over time it could gradually moderate. The challenge with an approach like that, of course, is you bake in the inequities from whatever the starting point is. So I think we have recommended consideration kind of on both ends of this. There is an example, national example, of a state that has actually put in place a price growth cap for hospitals. It's Rhode Island. It's not a very big state. Doesn't have as many hospitals as Massachusetts for sure. But they, as law, basically restrained what the annual growth was. And that proved to be the most successful intervention that they did for creating cost containment in their state. And there's been peer-reviewed literature that has shown that there were no apparent negative impacts from the implementation of that policy. How do we do this? Let's be thoughtful. Let's use the data. Let's model it out. And how do we do this, not in a way that's going to cause disruption to our healthcare system, but to do these things over time. I think that's a big part of this effort, is that this is a long-term goal and strategy. We've been at this for 10 years. I think we plan to be at this for the next 10 years. Anything that this legislature does to, as I shift into the final part of the presentation, as we have recommended, to evolve our approach. If the legislature passed a bill tomorrow, it's going to take us a year, 2 years, to go through the types of regulatory process, the modeling, the data. So how do we set ourselves up for the future? And I think that we have identified, if you don't mind, and maybe I'll just keep going into this, a couple of main priority areas that I will close with. First is just to say that we've heard from our data team here, the Health Policy Commission, we are not passive to the trends that we just have all seen. We are actively trying to work to moderate these trends through the levers that we have. We do not have the authority to cap pricing. Our main, only accountability mechanism for the benchmark really is the performance improvement plan process, which we've used just the one time. But we do want to use our other levers. So we do a lot of research and reporting, as David has shown. We create partnerships with providers. We make investments into hospitals to work together to design new ways of delivering care that can meet these goals. We've invested over $100 million in community hospitals across Massachusetts in the last 10 years. We're a convener. Just today is an example of how we can have a huge, thorny, noisy problem and bring it to this a conversation with incredibly thoughtful expert people to say, like, what do we do about this? And we have recommendations, but we are not, so we are humble enough to know that this is an opportunity for dialogue and conversation, not just amongst government and HPC and CHIA, but with the stakeholders who are behind me, who are going to be testifying. We all have to be committed into this together. And then finally, we as an independent agency do have a responsibility to be a voice for the people who are struggling to pay for healthcare, and we will continue to use that voice. So those are our four levers as we think about them. When we think about our agenda, and this is a list of some topics, non-exhaustive, I will say, that we discussed at our last board meeting around kind of our agenda for action this year. We need to continue to think about our cost containment activities and ways we can evolve our strategy. We need to bring together people to talk about workforce and identify solutions. We have to embed health equity in every single thing we do. The pharmaceutical part of our healthcare budget is in large part exempt from all of the other accountability and transparency mechanisms that are part of this law, all of the things that we impose on providers and health plans, they are often exempt from. This is a shared responsibility initiative. They should be part of the table, and not just manufacturers, pharmacy benefit managers, the entire chain. We have to address unnecessary complexity and reduce the administrative burden on providers and bring research and data to bear on all of that. Just quickly on these first two. So bolster the Health Policy Commission's cost containment activities. In our last report to the legislature, in our cost trends report, we made a number of policy recommendations, but here were some of the ones that we really thought were worthy of attention and focus. One is really thinking about the benchmark again, and how is this, as you said, Senator Friedman, the right number? Are there other contextual numbers that we need to bring to bear? It is a bright line test. And the HPC does that work of saying, okay, where are your pricing? Where is your market? What patient populations do you serve? Perhaps we need to signal more early in this process that providers that are providing extremely high value, that you can grow a little bit faster than the benchmark maybe. And so right now we are very restrained in the statute in terms of how that benchmark is set and how it is used. I think more flexibility and more figures that we can bring into that process could help send a signal to the marketplace about the areas we want investment in and the areas where perhaps over time we want to be able to restrain growth. We have to look at pricing. It is a part of the driver here, and doing so in a responsible way over time is possible. Pharmaceutical pricing and the industry needs to be brought into this. And then Senator Friedman, absolutely, the health plans have to be at this table too. And so I view these three things as truly a kind of comprehensive package. No one sits alone. If we're going to work with our providers and pharmaceutical companies to try to reduce these pricing, we have to ensure that those savings are actually passed on to the people who are paying their premiums. And so how do we create more standards and accountability on our health insurance plans? So we have laid out this menu. We are enthusiastic about the opportunity to work with the committee over this legislative session to really dig down into the details about how we might do this. Do we need to phase things in over time? Are there triggers so that we're not causing an unnecessary disruption at a very fragile point in our healthcare system? We are cognizant of all of those pressures. And there is no bigger pressure, I think, right now than about the healthcare workforce. And so on this point, I wanted to promote and invite all of the members of the committee and the public here today and viewing online to an event that we're going to be holding in just 2 weeks' time at Suffolk University Law School. We're going to be issuing some new research and reporting on the state of the healthcare workforce in Massachusetts, and again, bringing together thought leaders to have a conversation about how we move forward. So with that, we are stand ready as a partner and a resource to you for the work ahead. Chair DeVoe, I will turn it back over to you for any final words.
Thanks so much, Director Seltz. Yes.
Oh, sure.
Sure, Senator.
So I want to go back just quickly to the commercial spending growth compared to Medicare and Mass Health spending growth, and tie that in with one of the points that was raised about Massachusetts having one of the highest rates of avoidable hospital use in the U.S. Relative to those points, do we have any data as to the number of Massachusetts residents putting off medical care? In one case, we've got them using care that's avoidable, services that are avoidable. In the other, we see what's happening nationally in terms of avoidance of the healthcare system. Do we have any numbers in Massachusetts relative to those that are avoiding the system because of cost?
Yeah, absolutely we do. CHIA fields an annual health insurance survey. That one is one of the key questions. I know that this number off of the top of my head, but there was a private survey that was conducted in 2021, that found that 48% of Massachusetts adults reported that they put off necessary care due to the cost of care. And when you then dig deeper, and I think it's always important to go deeper under some of these averages, and you break that down by Black residents and Hispanic residents in Massachusetts, those numbers increase to 60 and 70% reporting foregoing necessary care. We are one of the most high-income states in the country. To me, this is an indicator that we can have the best healthcare system in the world, but if people can't afford to access it, what have we accomplished? And so, sobering numbers and a challenge, and something that I know CHIA will continue to track.
And just finally, 2 points. Is there modeling being done to assess what would happen if we do a better job at connecting people to services, particularly in underserved communities? Is that modeling being done? And then is there, or has it been, a comparison between outcomes? We see commercial spending growth increasing significantly faster than Medicare and Mass Health. Have we been able to look at the outcomes? Is commercial insurance providing greater access and getting better outcomes for their insureds compared to the state provider programs? And are we following, and I know this may not fall within the realm of your responsibility, but is there any coordination to follow those that have not accessed care when they should have, or those that have accessed care because they've had greater coverage, to find what those health outcomes are?
Yep. So kind of outcomes for the different kind of market segments, commercial versus others, I think I will have to get back to you on that. What we actually do know from the CHIA survey data is, or I think it actually was maybe the other survey I was mentioning, but if you tracked those same people who said that they had foregone care because they couldn't afford it, those same set of patients or residents were much more likely to report that their last emergency department visit was for something that they thought didn't need to go to the emergency department for. So these people are avoiding care due to cost and then ultimately showing up in an emergency department. To me, that is an indicator of an inefficient use of resources.
Yeah, that's the CHIA data.
Thank you.
Yeah, we have a case of too much care for some and not enough care for others. It's a vexing problem, and it happens in healthcare all across the United States. It's absolutely true.
Thank you.
Thank you. Well, it's painful for me to have to stop this discussion because I can see that we've, through the presentation, spurred a lot of thinking and good dialogue. But I do feel like while there may be other questions, we'll ask that those get directed separately offline to our presenters. And I'll ask that we move forward to begin to hear the public testimony for those who have registered to provide that to us today. And Director Seltz, if you're ready to coordinate the public testimony.
Sure. So we are going to go in the order that we have here. So we're going to start with Chris Carlozzi from NFIB, and just so that people know who is on deck, next we'll have Liz Leahy from the Mass Association of Health Plans.
Welcome.
Thank you. Thank you to the chairs and thank you to the members of the committee. My name is Christopher Carlozzi. I am the State Director for the National Federation of Independent Business, NFIB. We represent small business owners from across the state, all sorts of industries, from retail, wholesale, service, hospitality, manufacturing, even agriculture. So we kind of run the gamut in the types of businesses that we represent. They usually average between 5 and 10 workers. So really your small Main Street businesses. And small businesses right now, as you all know, face no shortage of challenges. Following the pandemic, they struggled with record high inflation, supply chain disruptions that resulted in empty shelves or paying astronomical amounts of money for materials, and labor shortages. In fact, according to the National Federation of Independent Businesses Research Foundation, from our February 2023 jobs report, nearly half of small businesses still have unfilled job openings right now. Roughly 21% of employers report labor quality as their top issue. And as employers desperately seek to adequately staff their businesses, they must be able to offer robust benefits packages, including affordable health insurance plans. But that has become increasingly difficult for Main Street businesses. The cost of health insurance affordability remains a top concern for small business employers, even with the added challenges following the COVID-19 crisis. offering insurance coverage to Massachusetts workers is a significant cost of doing business and has an impact on overall job creation. Year after year, employers often discover that Massachusetts remain below the health growth benchmark, a benchmark set by the information gathered at this hearing. Yet each year they experience their premiums steadily rising, while more of their budget is depleted by health insurance expenses. NFIB decided to survey our Massachusetts members, asking if their premiums increased, decreased, or remained the same. This year, respondents reported an average increase of 11.8%. And this is probably something you're going to hear very similar numbers from John Hurst later with similar small business members. I know Dr. Auerbach mentioned earlier, 6 to 8% under 50. And as I said, our members roughly are between 5 to 10 workers on average. So this is a problem. And when we asked them and surveyed them, we asked for some of their comments, and here's just a few I collected from that report. It keeps going up with nothing extra. We had to settle for a plan with higher deductibles just to make it close to affordable. Rates always increase annually with reduced benefits. Had to start a self-insured plan, and this business had 6 workers. And the most disappointing comment, thinking of moving out of Massachusetts, which I'm sure is not just because of health costs. When the cost of offering health insurance rises for a small business, there are consequences for both the employers and their workers. I have talked to business owners, and I know, Senator Friedman, you were our guest speaker last year at our Small Business Day and heard from some of these members directly. But I've talked to them in these unfortunate scenarios that often result in high deductible plans, shifting more cost to workers, or reducing other benefits. It is just the harsh reality of operating a small business in a high-cost state like Massachusetts. And this makes it more challenging to attract workers, especially when competing with large businesses and even government positions with the ability to offer more affordable, higher quality plans. The soaring cost of health insurance truly places Main Street employers at a disadvantage. Some argue our unique merged market results in an unfair cross-subsidy scenario, with small businesses paying higher premiums while individuals in some cases pay less. When the 2006 health reform law passed, merging the individual and small group markets, a series of ratings factors were in place at the time, however, gradually have been reduced and factored out over time and completely phased out now. So for all these reasons, we feel that the cost growth benchmark should be adjusted to lower than the proposed amount, back down to the 3.1%. Main Street businesses across Massachusetts and their workers cannot endure ever-increasing health premiums. So we should act aggressively to make health care affordable. Furthermore, the state must begin to investigate and address the impact of the merged market and its role as a barrier to affordability for small employers and their workforce. So with that, I'm happy to take any questions.
Any questions? I have a question about whether your members then default or use the connector as a pathway for coverage.
Some may use the connector. I mean, various sources. They didn't cite in the survey, specifically where, but there are cases where I've talked to members who have shopped on the connector to look for a plan.
Thanks.
Thank you. Thank you.
Thank you.
Thank you very much. Appreciate the time.
Thank you. And Liz Leahy? Great. Welcome, Liz.
And we'll have Steve Walsh on deck.
Good afternoon. Thank you, Director Seltz, Chair DeVoe, HPC Commissioners, Chair Friedman, Chair Lawn, members of the Healthcare Financing Committee. I'm Liz Leahy, Senior Vice President of Advocacy and Engagement at the Massachusetts Association of Health Plans. We represent 14 health plans and 2 behavioral health organizations that provide coverage to nearly 3 million Massachusetts residents across all lines of business. I appreciate the opportunity to provide our comments today. In years past, I've offered our support for a strong benchmark set at potential state gross product or below, and have highlighted the persistent underlying drivers of healthcare costs in our state. And this year, my comments are no different. While we know that the impact of suppressed healthcare utilization in 2020 resulted in increased utilization and healthcare expenditures in 2021, making year-over-year measurement difficult, this does not and should not mean that the benchmark is irrelevant. The cost growth benchmark is a vital part of the HPC's cost containment mission. and an important reminder that healthcare cost growth is a shared responsibility. But it certainly seems like the commitment of all healthcare entities to the benchmark has begun to fray in recent years. At last year's benchmark hearing, representatives from hospitals and provider organizations requested that the HPC and legislature suspend and replace the existing framework, while others recommended the HPC set the benchmark at a significantly higher rate to account for inflation. These recommendations were made in light of the COVID-19 pandemic, but the very same factors that challenged our ability to meet the benchmark prior to the pandemic continue to exist today. The first, persistent increases in the prices that doctors, hospitals, and other providers charge, often driven by market leverage rather than quality of care. The second, care increasingly and largely being delivered by high-cost providers in high-cost settings. And the third, continued excessive spending growth for prescription drugs. These cost drivers are not new. In fact, since Attorney General Martha Coakley's seminal report in 2010, over 30 state reports from the HPC, CHIA, and the Attorney General have confirmed that these primary drivers of healthcare costs continue to challenge our ability to meet the benchmark and to provide affordable, high-quality healthcare to our state's residents. Like the key drivers of healthcare costs, the solutions to address these drivers are also not new. MAP and our member plans have long agreed with the HPC and advocated for accountability to the benchmark for pharmaceutical manufacturers, joining with payers and providers in participating at the HPC's annual cost trends hearing and providing much needed data to the HPC, CHIA, and the Attorney General, as envisioned in last session's Senate PACT Act, filed again this session by Chair Friedman. It is a grave disservice to our state's cost containment efforts for pharmaceutical companies to continue to be absent from the conversation, particularly as prescription drug prices continue to outpace inflation and price increases for any other medical commodity or service. Similarly, we strongly support longstanding recommendations to ensure full system accountability to the performance improvement plan process, adding hospitals and pharmaceutical companies to those entities subject to a PIP, as well as a much-needed analysis of labor costs for hospitals and providers in Massachusetts in comparison to other similar markets. As we continue to hear from hospitals and health systems about the workforce challenges they are facing, this data will provide a much-needed foundation for policy discussions. But in the decades since the HPC's inception, these recommendations have not been advanced. Instead, healthcare policies that have added cost to the system have been enacted. 45 health benefit mandates requiring Massachusetts health plans to cover certain services have been enacted, adding approximately $2.5 billion to premium costs. Since 2012, payers have expended approximately $3.1 billion for new or ongoing government fees and assessments to fund a variety of state programs and agencies. And in this same time period, efforts to erode fundamental health plan tools used to contain costs have cropped up again and again. This session, there have been about 37 bills filed to limit, modify, or eliminate prior authorization, 56 bills filed to limit or eliminate consumer cost sharing. There were even 2 bills filed this session to prohibit carriers from utilizing the cost growth benchmark in negotiations with providers. Without these tools, health plans will be left with few resources to contain costs for the employers and consumers that they serve. Health insurance premiums are a direct reflection of the cost of care. When pharmaceutical companies, hospitals, and providers increase their prices, employers and consumers bear those costs in their premiums and cost sharing. Efforts to eliminate cost sharing, even for a certain subset of services, will not contain costs. Instead, removal of cost sharing will hamper the ability of health plans to effectively manage healthcare costs and will lead to higher premiums, a potential 15 to 30% increase in premiums if all cost sharing were eliminated. This is because even minor changes to cost sharing will change a product's actuarial value, governed under the Affordable Care Act, as well as its premium costs. If we truly want to address consumer out-of-pocket costs, we must address the underlying drivers of healthcare costs. Similarly, utilization management tools like prior authorization are used in limited circumstances to lower patients' out-of-pocket costs, protect patients, and prevent misuse, unnecessary, or potentially harmful care, and to ensure that care is consistent with evidence-based practices. Eliminating prior authorization removes an important check in the healthcare continuum aimed at ensuring access to high-quality, affordable, and appropriate care. I'll leave you with just an anecdote. So in recent months, MAP member plans voluntarily waived prior authorization for admissions from acute care hospitals to post-acute care facilities at the request of then EOHHS Secretary Mary Lou Sutters. And during that 90-day time period, one of our MAP member plans, who is monitoring this very closely to understand whether they should waive prior authorization altogether for this service, reported a 50% increase in use of out-of-network facilities and providers, raising costs for the employers and consumers that they serve, as well as over 100 members admitted to inappropriate sites of care. This experience of just one plan illustrates the importance of utilization management in ensuring that patients are receiving the right care at the right time and in the right setting. Now more than ever, action must be taken to curtail continued increases in both unit price and total medical expenditures here in Massachusetts. The healthcare cost growth benchmark is an important tool to meet these goals, and without a strong benchmark, we lose the needed shared responsibility necessary to hold all entities accountable for healthcare costs in Massachusetts. Thank you.
Thank you, Ms. Leahy. Any questions? Yes, Commissioner Howe.
Can you tell me what the association, the member plans are doing on behalf of streamlining administration for providers' offices and for hospitals, so that seems to me is the low-hanging fruit. No one's asking you for more administration, certainly. So is there any effort to unify and make it more uniform and simplify the process so that we can expedite care?
Absolutely. So I can speak to a couple different initiatives that the health plans have been engaged in. The first is a longstanding program through the Mass Collaborative, which is a voluntary organization comprised of payers, providers, trade associations. Its steering committee is led by principals from MAP, the Massachusetts Health and Hospital Association, the Massachusetts Medical Society, and Blue Cross Blue Shield of Massachusetts, together with the Mass Health Data Consortium. We've been working on streamlining prior authorization for a long time under the charge of Chapter 224, developing standard two-page paper forms that serve as the basis for prior authorizations. In recent years, we've also worked with NEHI, that has been working with the HPC, and I believe will be presenting to all of you in April, on a project exploring the end-to-end prior authorization process, identifying pain points and barriers, and making recommendations for streamlining those processes. That first report recommended automation of prior authorization as the #1 goal. And so as a result, MAP and our member plans have been supportive of NEHI's work to date, fleshing out what those parameters of automation would look like in line with the federal rules that have been proposed and what would be required here in Massachusetts. Automation won't be a silver bullet. It's not going to solve all of the administrative complexity concerns that are raised by folks across the healthcare continuum, but it's an important step in expediting the prior authorization process and creating a very important framework that we can see data and trends under. I'd also be remiss if I didn't talk about the work that plans do annually, reviewing their prior authorization policies and other administrative requirements to ensure that they're in line with best practices, checking in with local and national providers to make sure that their evidence-based standards are appropriate. And I'll stop there on prior authorization. We also have been working with Healthcare Administrative Solutions, which is a central clearinghouse for provider credentialing. They do an excellent job allowing providers to input their information just once, and then it goes to all of the health plans for credentialing and enrollment. This was a significant issue that was raised in years past, and so that's been addressed. And finally, the plans have been working closely with HCAS and CAQH on streamlining and improving provider directories. Provider directories are certainly a significant challenge for consumers, as well as for health plans and providers in getting the right data. So we have worked to establish, again, a central source where providers can enter their information once for all health plans provider directories, and then it will go to all of the participating plans. So certainly steps are being taken, and we acknowledge that there is more work to be done, but MAP and our member plans are at the table.
Any other questions or comments for Ms. Leahy? Thank you.
Thank you very much.
Thank you, Liz. Welcoming Steve Walsh, President and CEO of Massachusetts Health and Hospital Association. On deck is Alex Sheff from Healthcare for All.
Thank you very much, Executive Director Seltz, and good afternoon, Chair Friedman, Chair Lon, Commissioner DeVoe, Secretary Walsh. Good to see you and all members of the Joint Committee and the Health Policy Commission. I'm Steve Walsh, President and CEO of the Massachusetts Health and Hospital Association. I appreciate the opportunity to testify before you today. I also appreciate the level of questions that have been asked throughout the afternoon. As it's clear, the team here is digging into some of the most important and critical issues that we all face. As you know, the challenges that we have in our health system and our hospital today, especially with the affordability of the system, as a central goal of the Health Policy Commission. At this time last year, we're beginning to talk about some of the new and intense pressures that was beleaguering our healthcare community, from record workforce shortages, severe capacity constraints, and the debilitating financial instability of a system that was struggling to recover from the pandemic. Now, as we meet today, unfortunately, most of those factors have not changed, and some have intensified. But they also represent a care delivery system that is evolving at light speed. We are proud that everyone involved in healthcare in the Commonwealth, from providers to state officials, have stepped up to be part of this evolution. I am equally appreciative of the recent work of this commission. Your efforts to reconstitute your priorities, to put workforce at the top of the list, shows your leadership, your understanding of the biggest pressure that we face, and your unique understanding of the greatest threat to our collective goal of affordability. The tenor and tone and the dialogue, the intellectual curiosity of the problem, and your commitment to the solutions-based approach is exactly what the Commonwealth needs and this fragile system needs to recover. And for that, I offer my thanks on behalf of our members, our caregivers, and the patients that we serve every day. Now, my concern as we collaborate today is that our approach to examining and controlling the Commonwealth's healthcare spending has not adapted at the same pace as our approach to building our workforce and changing our delivery system. I want to revisit a piece of my testimony from last year regarding the legislative intent around the creation of the benchmark, as I think it's even more germane today. I know David gave some of the historical background on Chapter 224 earlier on, but in 2012, we made a historic move to set a benchmark. It was carefully based on the assumption of smooth growth, inflation, and overall economics. Of course, the current financial realities facing our healthcare system and our Commonwealth writ large are as volatile as ever. The original idea for the benchmark was that it would be set at roughly 1.5 points greater than inflation, which was averaged at 2%. That would be incredibly unrealistic at this extraordinary moment for the healthcare system and would only set up for failure. Inflation now at 7%, which would mean that the benchmark needs to be at 8.5% or higher, simply to be consistent with the way that it was created and envisioned. Now, that's what I said last year. So as you know from the presentation this morning, if you just took 1 year, the growth would have been 9%. We were right on a year ago, predicted exactly what would happen if we did nothing to evolve the way we think about this. The benchmark simply wasn't designed to measure the biggest cost drivers in today's market. Healthcare providers have done whatever it takes to adjust to those cost pressures and remain accessible for their patients. And those measures have come with staggering prices. Like the earlier question on Medicare, Representative Worrell, we simply can't control all of the input costs that hospitals and health systems pay every day. For instance, we now know that hospitals spent more than $1.5 billion on travel labor in fiscal year 22 alone. A 610% increase from pre-pandemic, 610%. If you back that out of the equation to create the benchmark, we absolutely crush it. This is the single biggest cost pressure for every hospital and health system as we speak. And there's no way to account for it in the current way we approach the benchmark. It relies on data from 2 years ago. There are other factors that are now fundamentally shaping healthcare finance and cost growth in Massachusetts. Rampant inflation, the impacts of deferred care, fast rising pharmaceutical prices, a landmark new Medicaid waiver, behavioral health, medical, and post-acute boarding crises, and the infrastructure improvements that providers are making to enhance their cybersecurity, respond to climate change, and build more sustainable facilities. Again, none of these factors were considered when the benchmark was constructed a decade ago. But now we have an opportunity to refresh the mechanics of our oversight model so that it can once again be a meaningful tool for you, the Health Policy Commission, the healthcare system, and ultimately our patients. MHA and our members believe we need to create a modernized system that can carry us through the next decade. Now, we have some good ideas on how this can be done, but we don't have all the ideas. It warrants a larger discussion with every single stakeholder in the room, every state leader, providers, payers, consumers, advocates, the life sciences, and beyond, to reimagine a cost growth benchmark that regain its relevance and its meaning. You, the HPC commissioners and members of this committee, have noted that the economic dynamics we find ourselves in today are just not sustainable for the healthcare system. And you are absolutely correct. We agree that we must get back to a place where cost and access are working in tandem with one another and not in conflict. That will take some bold new measures and some difficult conversations along the way, but now is the time to do it. When we think about access and affordability, we are thinking about the future. We are thinking about telemedicine. We are thinking about our new landmark waiver focused on health equity. We are thinking about hospital at home. We are thinking about remote monitoring. We are thinking about mobile integrated healthcare. We are thinking about interoperability. None of those things were around in 2012. None. And candidly, providers that are stuck in 2012 are not faring well. Payers that are stuck in 2012 are not faring well. Delivery models that are stuck in 2012 that believe disruption and change are the problem and not the opportunity are not faring well. So the simple truth is this: a benchmark that cannot reflect the realities of today is not a benchmark that can serve the cost needs of today. And an approach that is stuck in 2012 will only hold us back. Over the past year, this commission has taken bold steps regarding the workforce and care innovation, and it shows that you understand how to imagine the future. No patient walks through the doors of a hospital, and some of our best hospitals in the world, and says, please give me your best research, your best advancements, and your best technology from more than 10 years ago. Please don't be stuck in 2012, or we will never get out of this crisis. MHA and our members remain fully committed to the work of the Health Policy Commission and ensuring patient access and patient affordability. And we're here as partners to help this tool find its new footing. Thank you again for your leadership, your support of our healthcare organizations, and your commitment to building an even better system for our patients and communities for decades to come. And I'm happy to take any questions.
Thank you, Steve. Questions for Steve Walsh? Yes, please.
Thank you, Stephen, for your testimony. And I know you've been working with the committee for quite a while in bringing the concerns of the hospital system here in Massachusetts to us. And I know, and I look forward to attending the workforce forum with HPC and CHIA. And I know Senator Friedman and I and the committee have been really trying to dig in with many stakeholders on what we can do on workforce. And I will just share a story, and Steve knows this, is my mother was born in Ireland. And she went to a school where she, out in the middle in a very rural area, and her friends were contacted by the principal of the school when they were 18 because England was going through a workforce shortage and a healthcare shortage. So they were recruiting Irish women, doctors from Africa, all over the world, a workforce that they didn't have. From 1940 to 1970, England was trying to deal with this workforce. And as all this discussion today comes around, everything seems to come back as a number one challenge is workforce. But my mother, when she went to England, there was free tuition, free room and board, and they also got paid a monthly stipend. Because other than that, those barriers for her and her friends who went, 3 of her friends went to England, was to just work in a national healthcare system, which obviously is different than our healthcare system. But my point is, the world has faced some of these workforce challenges before. And we really need to do in Massachusetts is think about how are we going to, all of these questions and concerns and costs, so much of it comes back to workforce, whether it's getting people out of a hospital, and this is just not nursing. As as Steve has mentioned, and many of you know, I think we're close to a 20,000 open position in our Massachusetts hospital system, close to 6,000 nurses opening, and the number one driver there is travel nursing. And we really have seen such a burnout in healthcare workforce, and I worry about the next few years, right, as people retire. We really got to increase capacity. We really got to do things outside the box. We really need to go into neighborhoods and show a workforce that's diverse. We need to show a path of how they get there, because unless we do that, we're never going to meet these challenges. So I appreciate your testimony. I understand the strain that our hospital system is under, and I look forward to working with you and HPC and CHIA and with the committee to try to solve some of these challenges. But I do know what we need to do is something bold. We need to do something different, and we need to do it soon. And so I look forward to working with all of you and all the stakeholders to try to come up with a solution. But my point too is the world has dealt with issues like this before. I think we can rise to the challenge here in Massachusetts and do it again. So thank you.
Thanks, Mr. Chairman. And your mother, your wife, your daughter, so certainly your family is giving to the nursing profession, to the patients in a way that most others are not. So thank you for that. It is our greatest crisis. Commissioner Foley knows this. His team has a great job training program. We need to be paying for training. I talked about in front of this group last year, I talked about an AmeriCorps type training program that Massachusetts could institute. It is the most important thing we do and the best investment that we can make in our pipeline. But we also need to learn from some of the disruptors, and I think there is an opportunity there. When we're spending $1.5 billion in travel and cost, there's something about travel nursing that is attractive to people. And healthcare has always been run with some level of rigidity. So what about that can we learn? Can we change the way we deliver care? Can we change the way we do shifts? Can we offer a little less restrictive hours in terms of the way we, for years, and certainly Secretary Walsh knows this better than anybody, but there's a really good patient safety protocol around having 12-hour shifts, because you only have 2 handoffs in a day, right? If you have 3 8-hour shifts, you have 3 handoffs, and there are less patient errors, but that isn't working for the worker anymore. So now the way to have better patient outcomes and patient safety is to make sure that we're adapting the needs of our workforce that have stuck through us through the most difficult time in our Commonwealth's history. So there's a lot to learn. There's a real opportunity for the state to invest in both upfront scholarship programs as well as loan forgiveness, AmeriCorps type training, partnerships with our brothers and sisters in labor. And I think we also have to talk about how healthcare is a vocation again and make people excited about delivering the care that we've come to accustom in the Commonwealth.
Thank you, Steve. Senator Friedman.
Thank you. Thank you, Steve. And I totally agree with everything you've said. I just would like to point out that your mom worked in a system that was funded by the state. That's how, it's public health, right? And I just feel like we need to be sure that all of the stakeholders are at the table when we do that. I completely agree. We need to change so much of what we do, and we need to make it more attractive, and we need to get people into the pipeline. But that means everybody has to contribute. The hospitals, the providers, the insurers, pharma, PBMs, everybody that has a stake in this. So I look forward to having this discussion and to keep talking about this and to solve this problem. Everybody's got to be willing to put skin in the game in a pretty fundamental way. So let's get to it.
Just had one quick question. Is there any projections, if we did nothing about the workforce issues in hospitals, what the cost would be next fiscal year for temporary staff? Have there been a budgeted out what that cost could look like? I think you said it was $1.5 billion for this. That's what's been spent since, I don't know what the date is, but in the next fiscal year? Is there any projections for how much will be spent if nothing gets done with the workforce?
There isn't, Commissioner. It's a good question. We had projected we'd spend $1 billion, and we spent $1.5, which is not a good trend. I will say, on the other hand, that the temporary workforce contract negotiations are based on supply and demand. And because other parts of the country are not seeing the capacity challenges that we're seeing at this moment, the supply is down, which increases the demand of travelers, and it lowers the cost a little bit. But if you have a company that's taking 19% off the top, it isn't going to the worker. As you well know, when you're talking to your workers, that increase in cost is going to the company. So I think there's other creative solutions that I know the Lieutenant Governor and her wisdom have talked about in trying to kind of build our own and looking at whether or not we could do a cooperative staffing model or staffing agency for the Commonwealth and do a 1% or 2% as an administrative cost, as opposed to the 19 or higher that some of the national companies are getting. It is just remarkable that we have allowed, you think about it in any other industry, you take your best employee and they leave one day, and then they get rented back to you at 4 times the cost and stand in the same spot next to the same person they were working with a week ago. We wouldn't allow this in any other industry. There would have been some kind of a national response to this, and that's what's been allowed to happen throughout the pandemic. It's really unfortunate.
Steve, do you have any insight into how our challenges around the bottlenecks that are occurring in discharging patients from hospitals to more appropriate settings, how that compares to others nationally? Is it a bigger problem in Massachusetts than it is for other states, or about the same?
It is a bigger problem in the Northeast. We don't quite have an exact handle on why. Mr. Blakey asked a good question earlier about the throughput issues, and we'll send you our throughput survey through Director Selt so you can have a better sense of it. But we're tracking the throughput, we're tracking behavioral health boarding, and the stuck pediatric survey that we've done. It's really remarkable how everything clogs at the end, which drives up length of stay. It backs up everything in the ED. And then for the elected members here, you're hearing from your constituents that are saying, why am I waiting 6 or 8 hours in the emergency department? What is happening? And it's not that, that's partly workforce. It's also partly the inability to move patients out when they're ready for discharge to a place.
Thank you. Any other questions or comments for Steve? Yes, please.
Steve, thank you for your report and your comments. I always find your thinking to be leading edge and cutting edge, so thank you for that. My question comes back to workforce, and I'm very much looking forward to the workforce program in a couple of weeks. You made a comment about how rigid and how structured our workforce in hospitals are. The opportunities to make a plan and to work and have a full life is challenging. What thinking can we do in terms of models? Because, we're one of the 24/7 industries. That carries a very different framework in terms of how flexible we think we can be. So what you're thinking about how we reframe that, to have those discussions, to bring people into the field and keep people in the field?
Thank you, Commissioner. It's a great question, and Commissioner Foley and I have had these conversations. I think first and foremost, we've started to do some focus groups with our frontline workers. We have to talk to workers. We have to understand better what's happening. When you think about it, and there's a few masks left in this room, and on May 11th, masking will go away. The public health emergency ends, and that's a day that we should celebrate in some way. But it's also somewhat of a terrifying day, because if you think about the caregivers that have taken care of our loved ones, they haven't had a break. They started this 3 years ago. They've been going nonstop. The rest of the world has gone back to thinking that COVID is over, and why wouldn't you think that? You lost proms, you lost funerals, you lost weddings, you lost a lot of stuff, you lost graduations, and so you're going back. The caregivers haven't been able to go back, and they just keep showing up again and again and again for the people that we care about, the people we love. It's remarkable what they've done. And so we as an industry have to think about it differently, and that balance, that quality of life. Secretary Walsh knows this, we talked about it at a previous board meeting. There's a great Amazon ad about hiring. And that's who we're competing with now, right? We're competing with Amazon and others. And it's a 30-second spot, and it says, I can only work Monday 2 to 4. You're hired. I can only work every other Friday. You're hired. I can only work Friday nights. You're hired. And we have to think about that, because that's the balance that some of our workforce is looking for now. And these jobs are really hard. They're really more difficult than they've ever been before. Patients are coming in sicker. The constituency is less patients. The wait times are longer. It's a difficult task. And so this is a unique time, and the right minds are here to do it, but it's going to take some real digging, and I'm looking forward to really appreciate the 29th and the commission taking this on, as I said, as a priority. I mean, you are really in a unique position as a solution-based entity to help with this, I believe.
Thank you.
Good. Thank you so much. Thank you for coming in person, Steve, to testify. Appreciate it.
Thank you, Steve. Up next, we have Alex Sheff, and then John Hurst will close us out.
Good afternoon. My name is Alex Sheff. I am Director of Policy and Government Relations at Healthcare for All. We're a consumer advocacy organization. We operate a helpline that takes around 20,000 calls a year, and we advocate for health justice in Massachusetts by working to promote health equity and ensuring coverage and access for all. Thank you for the opportunity to testify today. The HPC benchmark is a critical tool to monitor healthcare costs and hold our system accountable for keeping costs under control, and so individuals and families aren't forced to choose between getting the care that they need and putting food on the table. I want to start by just briefly discussing some of the findings from the CHIA report, a lot of which have been discussed already. It was obviously a time when the state continued its uneven emergence from the pandemic. One thing that stands out in the report, again, this has been noted a lot, is the consistent and somewhat startling growth in prescription drug costs. Prescription drug spending grew at an annualized rate of 7.5% in the report's 3 years, accounting for rebates, which is important, and there was no dip in 2020 for that. Between 2020 and 2021, the most recently reported year, pharmacy spending grew 11%, and prescription drug spending was the largest component of growth during the 3-year period, and that warrants note. There are also some concerning trends regarding health insurance costs in the commercial market. The report showed, as we've talked about, a 4.4% increase over the 3-year period and a 6.8% increase in premiums from 2020 to 2021. And as the report notes, it surpassed both wage growth and overall inflation. So let me translate. That means that premiums are continuing to eat up more of people's hard-earned paychecks. That's the problem. But just as concerning, and this has gotten some discussion as well, is the growing trend of Massachusetts residents enrolled in high-deductible health plans, which grew 8.8% from 2020 to 2021. And David noted the even longer trends in that direction. These plans often require people to pay thousands of dollars out of pocket before their coverage kicks in, and it really does put care out of reach for many people. Ultimately, we know that these trends result in 41% of Massachusetts residents, that's the CHIA number, facing challenges affording care. People forced to skip doses of medications or cut pills. There are significant disparities, and I'm also happy to elaborate on this, but we know that Black and Hispanic Latinx residents are much more likely to face these challenges affording care than their white counterparts in the state. I do just want to say data is only part of the story, and this has come up a couple times, but we hear daily from callers on our helpline about the challenges they face affording and accessing care, so I just want to share a couple stories. One helpline caller is an electrician from Dorchester, said that he pays $240 a month for a plan on the connector. His prescriptions cost about $60 a month in copays. And he's been delaying seeing a doctor about the pain in his wrist. He's an electrician, and he's concerned about the additional costs. That's why he doesn't want to go back to the doctor. Another caller, a woman from Waltham, who works at a school, and her husband is a landscaper. She pays over $400 a month for a connector plan for her family. She has diabetes, and her husband has a heart condition and gout. all of that requires regular care and treatment, and it adds up in terms of out-of-pocket costs. She noted when she called us that other members of her family have died from diabetes, so she's really vigilant about her health. But cost of care is starting to become prohibitive, and it's causing a lot of stress for her and her family. And these are the experiences that really resonate, and it's why Massachusetts must remain focused on the question of how to blunt the rise in healthcare costs. As the HPC considers the new benchmark, we believe it should aim for consistency. The spending growth rate over the most recently reported 3 years was averaged 3.2%, and that indicates that the previous benchmarks have been reasonable relative to spending. But just as important, and this starts to broaden the conversation, just as important as this conversation, there are two key considerations we see facing the HPC and the state as it balances some really important competing needs. First, the HPC must consider how to balance the immediate workforce challenges with the challenge of making sure people can afford the care that they need. And this is really important. We shouldn't feel forced to choose between solving only one of these problems. We have to address both. Both a lack of available services and prohibitive costs for those services pose a threat to consumers who are trying to get access to the care that they need. And we need to be future thinking around this. In weighing these competing demands, we recommend that HPC take the broadest possible view in examining the capacity of different entities to weather cost challenges without passing a disproportionate share of that onto the burden of consumers, individuals and families. So for hospitals and health systems, this could require looking beyond just operating margins to reflect on additional information in audited financials, such as things like cash on hand, to look at liquidity. For insurers, it may be looking at variations in risk-based capital beyond just what they're required to have in reserves. So that's the first piece. The second key consideration for the Health Policy Commission and the state is to reflect on the lessons learned from the 10 years of experience that we have with the cost trends process with this eye to the future. There have been many successes. We've noted that ones that other states have really sought to emulate. We are a model. But there are also some areas where updates, and Steve just made this point, where updates really do make sense. We believe that a couple of those updates, and I'll just tick through a couple of them that are important. The first, and David brought this up already, is tracking a specific consumer cost benchmark, right? To Senator Friedman's point, what are we measuring that matters to people? As well as, and I want to add this, some health equity benchmarks. I think that should be part of the consideration of a consumer benchmark as well. The second thing is thinking, and this jumps out from the data, bringing prescription drug manufacturers as well as PBMs into the cross-trends process with all the necessary reporting and transparency and accountability that requires and that other industry stakeholders are held to in the state. And then thinking about adjusting the measures used to refer entities to the Health Policy Commission for review, including maybe non-risk adjusted costs, hospital cost growth, and relative price growth. And then finally, thinking about more meaningful penalties for non-compliance with the PIP process, which is the only tool right now the HPC has, and that's following the lead of other states like California that looked at what we did and said, they did a great thing, but let's see if we can take the next step in that. All of this has to be done with an explicit mission of improving health equity. So we have to think about expansions in service capacity should be focused not necessarily in the wealthiest and whitest communities in the state, but in neighborhoods that need those services the most. Reducing disparities and burdens of healthcare costs require building equity into the system. And that includes policies from these consumer and equity benchmarks to encouraging smart benefit designs around cost sharing. So thank you, and I'm happy to take any questions.
Thank you. Questions? Any questions? Good. Thank you so much.
Absolutely.
Thank you for your testimony.
Thank you.
Thank you, Alex. And now we have John Hurst.
Thank you very much. Good afternoon. Thanks for hanging in there. in doing this important work for all consumers and taxpayers in the Commonwealth. My name is John Hurst. I'm president of the Retailers Association of Massachusetts. We're a statewide trade association of 4,000 members, primarily small businesses across the Commonwealth. I am here today to urge the Health Policy Commission to consider returning to 3.1 as a benchmark. Look, whatever we're doing is not working. Small businesses are absolutely struggling. Their sales have been flat, and the last 3 years obviously have seen countless numbers of stores and restaurants and others that have gone dark. And there's others that are just simply on edge. They've been hanging on little by little, month by month, and just hoping that either their sales will rise or their costs will drop. Unfortunately, both are heading in the wrong direction. Sales are flat to down, and their costs are simply skyrocketing. We, like Mr. Carlozzi, we did a member survey. We've been doing this every year since the benchmark hearings have started, and hot off the presses for the spring renewals for our members, it came back at 11.7% increases. And now not everybody is going to pay 11.7%. Some were adjusting, like 20% changed carriers, 27% increased employee cost sharing. I thought our members were essentially at the cap of that, but nope, they're going to continue to do whatever they can to keep on giving their employees some level of coverage, and 3% drop coverage. Now, if this was a one-time fluke, it'd be one thing, but it's not. As David can attest, me coming in here year after year after year, the decade average for our members has been 9.61%. And you compare that with average increases, say, of the GIC of about 4%. You compare it with 2% inflation rates, and you wonder, and it's 3 times their rate, their average increase is 3 times the benchmark, 5 times inflation. How is it, are these small businesses really 3 times less healthy than, say, a big business or employees of government? I don't think so. Something's going on here. It's not right. It is the question that I believe the HPC and the legislature have to tackle in the next 2 years. A real issue, and David Arbach kind of alluded to it. The DOI reports that there have been 400,000 small group lives that have vanished, disappeared since 2007. Where are they? I think that's something that our public policy officials need to make a priority to determine what happened. Is it cost? Is it bad public policy? What is it? We need to know where they are. I do believe that we need to look at the merged marketplace, which dates back to Romney Care. We put individuals and small group together in the same merged market, unlike the other 49 states, and we did that to help out individuals. And that was pre-ACA, which of course helped individuals through tax subsidies. So post-ACA, we never went back and revisited that issue. And we had rating factors that were intended to try to properly distribute the cost, the claims within the merged marketplace. The rating factors went away as well. So, for instance, the size rating factor, it used to be if you had 25 employees. You did a little bit better than someone with 2 employees, or if you had 50 employees, you did a little bit better than someone else. Today, if you have 50 employees, and if you're still in the merged marketplace, very few are, I believe, you would be essentially buying 50 individual policies. That's the way the current public policy is in Massachusetts. That's pure discrimination for small businesses. It's bad public policy. And then you add in another increased cost for small businesses. You look at state mandates. So you have a lot of employers even going right down to 25 or even 5 going with stop loss, self-insured. They follow federal law, and therefore the 10 essential benefits under the ACA. They don't necessarily have to follow all the state is all the state mandated benefits. And the DOI just 2 weeks ago put out a survey for the end of 2021 that looked at 32 state mandated benefits. They found 0 of those 32 mandated benefits where all the self-insureds were covering them. Now, 0. All small businesses in the merged marketplace have to cover all 32, fully cover them. Now, some of those self-insureds were covering them, but not at a full level. So if you start looking at raising questions, why are small businesses paying so much more than big businesses or even government for comparable coverage? I think we have to look at two things. We have to look at spiraling provider costs, and we have to look at perhaps antiquated public policy. We've got to look at those two things, David, and we need to look at it as the top priority. And finally, I would just add, as far as the providers, look, I sympathize, but, small businesses, they aren't getting tax subsidies. They aren't getting, huge increases, both whether you're a private payer or a public payer. In fact, I think an unmentioned question here, we know that there's going to be a whole lot of redeterminations coming in the coming months. I'm no expert, David, but what happens for someone moving from Mass Health to a commercial plan as far as provider reimbursements? Presumably, the providers are going to see a very large increase in revenue from a couple 100,000 people moving. That needs to be considered as you go forward and look at a new benchmark moving forward. So, look, small businesses are struggling. We need small business advocates. We need more business groups to be small business advocates. We need state policy leaders appointed and elected to be small business advocates, and we look forward to working with all of you in the session to come. Thank you very much.
Thank you. Questions for John Hurst? Commissioner Cohen?
Thank you, John. I run a small business. Sorry, I'm not a retailer. 5 employees. We're going through that April renewal process. A family plan is $40,000 a year. It is now our second biggest expense other than payroll. So I appreciate what it means to a small business owner to have those costs. I also just want to say I appreciate your raising the redetermination process, because I think it's going to have a huge impact not only on families, but on what it means for costs in the Commonwealth. So thank you.
Right, and where are they going? Will they go to the merged marketplace, and will that therefore have further impacts upon small businesses that are remaining in the merged market? It's a real question that we have to answer.
Good point. Yes, Senator Friedman.
I have a question about the issues around the merged market. So the commission found that the risk scores for the two groups, individual and small businesses, were largely the same. I think it was 1.36 compared to 1.31. So can you help me understand why you think the connector care is more expensive, and why you think those individuals are raising rates for small employers?
Well, the commission, Senator, did show that small businesses are still cross-subsidizing in individuals by about 4%. When we started off back in 2017, it was far bigger than that. But, it's gotten smaller. But I think it's gotten smaller, frankly, because those 400,000 small group lives have evaporated. They've gone elsewhere. At the same time, individual lives have gone up. So I think the cross-subsidization certainly would drop because of that.
So you don't, okay, but that's not based on information from the commission. That's just based on what you perceive to be what
No, that was in the governor's merged marketplace report. A 4% cross subsidization of small group versus.
But again, that my understanding actually was not. That was actually based on some very people going to the connector that were paying for very large, very expensive plans. So I just want to make sure that, I mean, that's what the commission reported. So I just want to understand, because I think
it's very
something-
complicated. I think it needs more study, Senator. I think it's there, but there clearly is a problem. Where have those 400,000 lives gone, and whether it's cross subsidies in the premiums, or is it avoiding state mandates that they're large competitors that they compete every day with for employees, for retention.
Let my colleague answer.
They've more than likely gone to Mass Health. I think our insurance structures don't really recognize the gig economy. Many of your employers, the employees who work for your businesses have 2 or 3 other jobs to make ends meet in 2 or 3 other small businesses, or they're small business owners themselves. So I think part of the redetermination challenge is people are going to be coming into the commercial insurance market either through Connector, or employers will be challenged to offer insurance to people who have had it through another mechanism for the last almost 3 years because of the pandemic.
No question, Madam Secretary.
You're going to be getting a letter from me asking for your help so we can get people and keep our best in the nation status in terms of insurance. So it's going to
take up rates, I think, will probably go up, and that's a good thing for small businesses. However, the premiums have to be fair, and because again they're competing with businesses of 51 and over, or even 25 that have gone self-insured. It's
I don't think there's any science between 25, 29, or 53 employees to say who's going to be sicker.
Other questions or comments for John?
Thank you all for your
so
work.
much.
Okay.
Thank you. Well, let me keep my closing remarks very brief, because I realize we've stretched it, and I appreciate everybody hanging in there. This has been a tremendously useful afternoon for us. I just want to acknowledge before we close that we are hearing loud and clear in 2 categories that we're listening to. First is our immediate challenge around our decision-making around recommendation about this year's benchmark for 2024, and the testimony and the presentations today, and that balancing that we go through every year, with every year having different issues and challenges, this was an essential afternoon as input to that. But I want to acknowledge that we also heard from the presenters and the testimony that we need to continue to evolve. And I know that both the Joint Committee and the Commission have strong views on how that can be done, and are eager to work together with others to make that happen. So I want to acknowledge both, and we will look forward to our next step at the HPC's April meeting to consider the benchmark. So thanks to everybody, and we'll now officially close.